Sumita Ghosh, madam, are you getting my voice?
Hear you.
Are you able to hear my picture also, madam?
Yes.
Yeah. Thank you, madam. The sir is about to join us. Within 1 minute, sir will join us. Then we will start immediately. Sir, please. मैडम सर ने ज्वाइन कर लिया है, शुरू कर दो मैडम।
Namaskar. Good afternoon. Welcome to all to this first webinar on facility-based newborn care, Do No Harm, by MoHFW Ministry with all the states. Respected Additional Secretary Sir, expert panelists who are present with us today, state child health nodal officers, maternal health nodal officers from the states, ASHA nodal officers from the states, doctors and nursing staff from SNCUs, labor rooms, and NBSUs, or newborn stabilization units, district officials, labor room in charges, representative from various professional bodies, our development partners at the national and state level, academics, RCC, our regional collaboration center focal points, child health team members. Welcome all of you to this webinar we are having in this National Newborn Week. Each and every one of us are an important pillar in India's journey to reduce newborn deaths and to our commitment to ensure every newborn is able to survive, thrive, and transform into a productive citizen of our country. We are celebrating National Newborn Week this time on the theme, ensuring quality, equity, and dignity of newborn care at every health facility and everywhere. The structure of today's webinar will begin with the introductory session, followed by 4 technical sessions by our clinical experts. We'll share the state experiences from various states. There'll be a question answer session, and then followed by final remarks from the MoHFW and vote of thanks. I would like all the participants to follow certain housekeeping rules. We have a packed agenda, and so I request all the speakers, experts to follow the time allocated. All participants will mute their videos and mute themselves, and they will put their videos in off mode to have least distractions during presentations. We have a large number of participants today already. How many joined? 4,000 have more than 4,000 have joined today. So please see to it that there are no distractions. If any query is there, please post your comments in the chat box and they will be answered. Any of you having difficulty in logging in, you can log in the YouTube link we'll share in the chat box. To begin deliberations of today's session, I am honored to invite Dr. Manohar Agnani, Additional Secretary, to provide us the strategic guidance and share his vision of newborn health in India with the participants. Dr. Agnani sir has been leading the national health sector as Joint Secretary Policy and National Health Mission, where he was instrumental in operationalization of health and wellness centers. And from November last year, sir has been heading the RCH division with a passion to strengthen our public health system. I welcome you, sir, for your talk.
Thank you, Dr. Sumita Ghosh. Good afternoon, and I welcome all of you on this important webinar on facility-based newborn care, Do No Harm. Uh, First, I would like to thank you all. My sincere thanks to all of you, and especially because all the efforts you all have made and support provided to us, to state governments. So I am congratulating, I am thanking all the development partners, all the state governments, UNICEF, WHO, NEPI, Save the Children, USAID, IP Global, professional bodies like National Neonatology Forum, IAP, for enabling us and establish the entire theme around which we are discussing today. Friends, it was 2014, India launched the Newborn Action Plan, which serves as a roadmap for improving newborn survival in India. We met our INAP targets of neonatal mortality rate, which was 24 in 2017. And now we have more ambitious target under National Health Policy and SDG, where we are progressing further. I just want to bring to your kind attention that yesterday our Honorable Minister, on the occasion of this week, has released the progress card of India between 2014 to 2020. Just want to show you a copy of that, which is available. Many of you participated in yesterday's event. And from that document, I just want to say that our India Newborn Action Plan prioritizes babies born too soon, too small, and those who are sick, as they account for majority of neonatal deaths. This plan aspires towards ensuring equitable progress for girls and boys, rural and urban, rich and poor, and between states and districts. So when I say rural, urban, rich and poor, I am reminded of my frequent visits to sick newborn care units in public health facilities. And I always say that's a model which we created in our country where the reverse referral used to happen. Many of the private establishments, clinics, doctors used to are sending these neonates to public health facilities, sick newborn care units. Another action plan component is identifies major guiding principles under the overarching principle of integration with equity, gender, quality of care, convergence, accountability, and partnership in focus. And health being a public good, I understand these guiding principles are apt under India Newborn Action Plan. It serves as a framework for state and districts to develop their own action plans, own with measurable indicators. We have very good monitoring system of sick newborn care units, NBSUs, and so on. We do review based on the outcome indicators, and we encourage all the districts and states to have their own action plans and monitoring framework. This India Newborn Action Plan also emphasizes strengthening surveillance mechanisms, I said, for tracking stillbirths. So, against this background, we all know that the 6 intervention pillars, India went beyond ENAP, I want to say here, where we included 6 pillars, so 5 known pillars of preconception antenatal care, second being care during labor and childbirth, third, immediate newborn care, and fourth, care of healthy newborn, fifth being care of small and sick newborn, we added the sixth one, which is care beyond survival under INAP. And I'm happy to say that our progress, India's progress on global ENAP targets for 2025, ENAP set 4 targets for us. We have already achieved 3 out of those in 2020, these being the skilled birth attendants at delivery, postnatal care with 2 days for mother and baby, and third, of course, the establishment of SNCUs, where 83% of the districts in India have at least one SNCU. So that's the progress, but just want to say that this progress, it doesn't mean that we should be complacent about our achievements. There's a long way to go. I monitor many programs in the ministry. Aspirational districts are one program where I see that many of the facilities in some of the aspirational districts are basic services are not available. If we monitor the outcomes of our actions, that's again a point which I want to bring to your kind attention. The neonatal mortality rate of our country has remained stagnant at 23 per 1,000 live births in SRS 2018, which was there in 2017 as well. While the under 5 mortality rate of 36 and IMR of 32 have shown only marginal decline of 1 point in SRS 2018 in comparison to SRS of 2017. So our concern is that our NMR remains much higher than the global average of 18 per 1,000 live births. So to reduce this, so we are bridging the gap, we are reducing the child mortality rate, under 5 mortality rate. So as a result, as a fallout, our contribution of the neonatal mortality rates toward child death is actually increasing. So around 60% of all under 5 mortality is contributed by this. So that shows the concern for which we are here today. We, in the process of these 6 pillars which we identified, with all your support, have started some good initiatives. So if I may be given 2 more minutes. On preconception antenatal care, we have programs like Pradhan Mantri Surakshit Matritva Abhiyan, Anemia Mukt Bharat, Rashtriya Kishore Swasthya Karyakram, Pradhan Mantri Matru Vandana Yojana. For care during labor and childbirth, we have done the Lakshya, which is Labor Room Quality Improvement Initiative. We are also have started on midwifery aspect, Dakshata for skill upgradation. JSY and JSSK are, of course, the old established programs. For immediate newborn care, we have a series of newborn care corners, Navjat Shishu Suraksha Karyakram, for which the guidelines have been revisited. Yesterday they were inaugurated, and of course the universal immunization program. For care of healthy newborn, we have Mother's Absolute Affection, home-based newborn care. And for care of small and sick newborns, we are having SNCUs and NBSUs network. Finally, for care beyond survival, we are the country where we have started RBSK, follow-up of sick infants who are discharged from the SNCU. And recently we have started an ambitious program of home-based care of young children. So friends, I welcome you all with this background. I understand that to achieve all this, every pregnant, I say every pregnant and every newborn, without exception, must have access to high quality services, not only during intrapartum period, but also before birth, and most importantly in the postpartum period. The team of obstetricians, pediatricians, midwives, and nurses, we all need to work together. And I hope that today's discussion will be very important. We have discussions on subjects of perinatal asphyxia, respiratory distress and oxygen therapy, identification and management of neonatal jaundice, and we will have experiences from states like Himachal Pradesh, Karnataka, Andhra Pradesh, Telangana, and Uttarakhand, and which will be, of course, have a question answer sessions. So I request you all, feel free to ask and share your concerns, queries as much as possible. All those doubts or queries that you share with us shall be answered during this webinar, but also later on a continuing basis. So with this background, I sincerely hope that you all will take advantage of this opportunity and take back with you the key messages and the learnings that will help you provide enhanced care of all newborns. I also want to request, please keep yourself and your family safe in this corona time, you being one of the most valued warrior in our battle against pandemic. Thank you very much. Namaskar. Jai Hind.
Thank you, sir, for your guidance and for your inspiring words, your concerns and your comment that we have a long way to go will be taken seriously by all who are present here today in this webinar. Thank you.
Thank you, madam. Now, I am delighted to invite Dr. Sumita Ghosh, Additional Commissioner and in charge Child Health and Adolescent Health. And she is providing us leadership of our department and for the all newborn kind of initiatives. She is a pediatrician having more than 35 years of experience in the health sector and leading maternal health and family planning programs also at the national level. Now, may I request Madam to kindly guide us on the facility-based newborn care status across the India. Madam, please.
Thank you, Dr. Kapil. I'll give you a very brief overview of our facility-based newborn care, what we are doing and where we have reached. So, starting, we have, sir has already said that our NMR is 23 and it is stagnant for 1 year. So he has expressed concern. We have a very huge cohort. We have 2.6 crores babies being born every year, and 15 to 20% of them are preterm or low birth weight, and so they need special care. So our facility-based newborn care program is geared for treating the neonates, giving them the essential services, as well as for treating these small and sick neonates. There is 60% decline in NMR in between 1990 and 2018, and which is a much faster rate than the decline in the global average. So where are the major concerns? Why this? Where we should look if you want to bring down this 23 figure to single digit? So the major cause is prematurity and low birth weight, 48%, birth asphyxia and trauma, 13%, pneumonia, 12%, major severe infections, sepsis, 5.4%, anomalies, congenital anomalies, they constitute 4% of deaths, and other things including diarrhea cause 3%. Our goal, which we have, which is INAP goal is single digit by 2030. Our national health policy goal is 16 per 1,000 live birth by 2025. And our SDG goal is 12 per 1,000 live births by 2030. So if we look at our national figures, we can see the 23, the India average. We have many states which have already, which are below this average, and the first three states, Kerala, Delhi, Tamil Nadu, they have already achieved SDG goal, and the 7 on the left hand side, they have achieved the national health policy goal below 16. But the ones which are the bars which are on the right hand side, they are yet to achieve the national average. Some of them are quite high, so we have special concern that all the states who are present here, we must see that our graphs come down adequately so that we achieve the national target. So our strategy is both facility-based care as well as home-based care. And in the facility-based care, we have newborn care corners for normal deliveries, the normal babies, slightly sicker babies we can stabilize at the NBCUs, and those which are small, sick, they can be treated at the district level, that is SNCUs. And we have specialist care system at the intensive care units, neonatal intensive care units, which are at the very tertiary medical college level. There was NICU. In home-based care, we have a big force of accredited social health activists, ushers in position, almost 1 million of them. They do visit the newborns at home, and we had 1.4 crores newborn visited in 1920, and of them 5.669 lakhs were referred for treatment of their sickness. There are entitlements, free entitlements for drugs, diagnostics, diets under our JSSK program till 1 year of age. There are newborn care packages both for preterm and for normal babies under the Ayushman Bharat program. So you all know this structure that NBCCs are at all delivery rooms and OTs. Our NBSUs are at the first level units, CHCs, and district hospital medical colleges have SNCUs, and tertiary centers have Apex institutes have NICUs. So I'll quickly go through the next slide. Sir has already said what are our various strategies, interventions we do from the national level. We do provide the guidance notes about infrastructure, HR, logistic budgets. The funds are provided to the states for establishment purpose as well as recurring costs. There are several capacity building programs for facility-based newborn care. Two of them, so said yesterday we had two of them updated, and new one for NBSU has been released. We have the Apex institutes which work as resource centers for hand-holding of the states in capacity building and mentoring. We have online, very well developed online reporting system from at more than 90% of our SNCUs, which give us real-time data. We monitor and then take informed decisions are taken by the states and at the national level. And we have a supportive supervision mechanism. These are the 6 pillars already touched upon, that it has to continue across the life cycle as well as in a continuous manner. The strategy is survive, then thrive and transform. We have our family participatory concepts where the families and communities, they take part in the development of the newborn. Our MNCUs are there, mother and neonatal care units. So in the SNCUs, where mother can actually be roomed in along with the babies. We have adopted KMC concept, kangaroo mother care concept, for the small and the preterm babies. There are various mechanisms for regularly monitoring and supervising the projects which are running in the states. There are online tracking, I said, and there are various mechanisms for strengthening our care system during both antenatal, intrapartum, and after that. So the SNCU doctors, nurses, and staff who are present here, this will be discussed very much in detail in next technical sessions. So what are the areas, how we can avoid unnecessary harm to the sick and small newborn? It will be discussed after this. Regarding data, go to data. Next. Yeah. So these are the very important critical monitoring areas which I will highlight with some data. The admission data, duration of stay less than 1 day. Why this is important? Because when the admission is necessary for less than 1 day, that means that the admission criteria may not be followed properly. Unnecessary admissions are happening. So the big graphs we can see on the left hand side, the states can themselves look at them and see that unnecessary admissions do not happen. Our SNCU beds are very important. They are priority beds for the sick and small newborns. So even if someone feels that the admission criteria are clearly defined, so we should stick to that and see that these units are not overcrowded, because that actually tells upon the quality of care in these SNCUs. Next one is about the use of antibiotics. The data is presented here. The lower graphs, the purple bars, they actually present the the sepsis rate, infection rate, and the upper green ones, they are actually the use of antibiotic in these states. So if we can see the sepsis rate 6.73%, whereas the antibiotic usage rate is 76.87%. So it is how many times? More than 12 times. So here is another concern. We must regularly monitor the data we receive from our SNCUs and see to it that antibiotics are used properly, they are used judiciously, because unnecessary use of antibiotics actually can cause lot of harm. They can cause resistance. Apart from that, they are actually positively harmful for the babies, resulting in necrotizing enterocolitis and various severe other complications. So we have to monitor this. The states, this is being presented for the states so that they can individually look at their own state, see that where it is happening. They can individually look at the figures from the facilities where it is happening, and then adequately train the officers there for proper use of antibiotic. The third one is about the successful discharge rate, as well as the ones which have left against medical advice, on the unfortunate deaths of the newborns. So here again we can see individually from the SNCU data monitoring, we can find out the exact figures. How many are living without medical advice? What is the cause? Why this is happening? whether we are losing these babies, whether they are being followed up. So these are areas of concern. We can monitor what is the percentage of deaths, the fatality rate. If they are high, we can find out what are the reasons why it is happening, what can we do about it, how we can strengthen our system to bring down the fatality rate. So even facility level data, everyone can see, and they can actually analyze the facility people. The district people can analyze the district data. The state people can analyze the state data. So here is a great scope for improving our quality of care in our SNCUs. I'm not getting into the individual state level data because that will you can with this data will be shared with you. You can go through it. Next slide. Next slide. Here is again a very important graph. What is the, we can clearly see that how ANC care is related to preterm deliveries. So we can analyze that data from our SNCU data, that how many of our preterm babies got adequate ANC cares. So we can see there is a reciprocal relationship. The ANC, the lesser the ANC is given, the more are the preterm incidences. So here again is a very important relationship we can make with maternal health initiatives, maternal health services, as well as our neonatal services. And we can see for ourselves where the ANCs are lacking. We can improve that, because prematurity, 48% of death. So that can be avoided if high risks are detected in the antenatal period. They are managed, and a lot of them can be prevented. So with this few slides, and there are so many other correlations can be made if we can look into our facility data, if we can look into our facility performances. So it is very important, and we must commit ourselves that our SNCUs function with quality. And one slide is not there, that we must see what is the equity aspects. Like often we find that male admissions are much more than female admissions. So the females neonates may be healthier, but still there is a scope. When there is a big difference, big gap, we must see why this is happening. So with these few words, I will now next session I'll invite Dr. Sushma Nangia. She's HOD neonatology at Lady Hardin Medical College, Kalavati Saran Hospital, and she's the coordinator in charge for our National Collaborative Center there, and she's also the vice president of National Neonatology Forum. She has 3 decades of experience, and she's a big support for us in our neonatology program. So I invite her for conducting the next part of the technical session. Welcome, Dr. Sushma Nangia.
Thank you, ma'am. And this is indeed a very good initiative where from the Child Health Division, we are having these kind of webinars. And I'm really thankful to Dr. Manohar Agnani, Dr. Sumita Ghosh, madam, and Kapil, who is there to oversee all the work that is being done. So, दोस्तों, हम लोग यहाँ पे 2030 लोग इस वक्त लॉग्ड इन हैं, और आप सबका बहुत स्वागत है कि आप इस प्रोग्राम में हमारे साथ में शामिल हुए हैं। हम सब जानते हैं कि पिछले 2 से 3 दशकों में हमारे देश ने काफी उन्नति की है। तो कई प्रोग्राम्स जो गवर्नमेंट ने चलाए हैं, हमारी सरकार ने चलाए हैं, जैसे कि सबसे पहले नेशनल रूरल हेल्थ मिशन शुरू हुआ 2005 में, उसके बाद में RMN-CHA प्रोग्राम आया, उसके बाद जननी शिशु सुरक्षा कार्यक्रम, फिर फैसिलिटी बेस्ड न्यूबॉर्न केयर, नवजात शिशु सुरक्षा कार्यक्रम, होम बेस्ड न्यूबॉर्न केयर, RBSK, इंडिया न्यूबॉर्न एक्शन प्लान और लक्ष्य। ये लिस्ट काफी लंबी है, पर ये हर एक चीज जो एक एक स्पेसिफिक एस्पेक्ट को एड्रेस कर रही है, और इन सब के चलते हुए हमने काफी प्रोग्रेस की है। मैं अगर आप सबको बताऊं, ये जानना अच्छा रहेगा कि हमारी जो अंडर 5 मोर्टेलिटी थी, यानी 5 साल तक के जो बच्चों की मृत्यु होती थी, उसमें हमने 70% का इजाफा किया है 1990 से लेके 2020 में। तो विच इज वेरी गुड। हम 126 से अब 36 पे आ गए हैं अंडर 5 मोर्टेलिटी का रिडक्शन, विच इज अगेन रिलेटेड टू मेनी ऑफ द प्रोग्राम्स दैट आर बीइंग डन। फिर जो इन्फेंट मोर्टेलिटी है, पहले साल की जो मृत्यु दर है, उसको हम ऑलमोस्ट जो है 65% घटा पाए हैं 89 से 32। लेकिन जो नवजात शिशु की मृत्यु दर है वो घटी तो जरूर है, ऐसा नहीं है कि वो नहीं घटी है, लेकिन उसकी जो गिरावट है वो सबसे कम है। तो वो हम करीब करीब 50-55% गिरा पाए हैं। और आज की तारीख में भी जो नवजात शिशु की मृत्यु दर है, वो जो पहले साल के बच्चों की मृत्यु दर का 3/4 हिस्सा बन रही है, और 5 साल तक के बच्चों की मृत्यु दर का 2/3 यानी 65-66% बन रही है। इस सबको एड्रेस करने के लिए हमें नवजात शिशु की देखभाल बहुत अच्छे से करनी है, जिसके लिए चाइल्ड हेल्थ डिवीजन ने ये वेबिनार्स प्लान किए हैं, ताकि हम एक एक टॉपिक जो है, जो एक एक इशू है नवजात शिशु की देखभाल से रिलेटेड, उसके ऊपर चर्चा कर सकें, और आप लोगों को जो भी कुछ डाउट्स हैं फील्ड लेवल पे काम करने में, उनमें आपका सुधार आ सके, इजाफा हो सके। तो इस सीरीज में आज हमने 3 एक्सपर्ट्स को बुलाया है, जिसमें हैं डॉक्टर आरती मारिया जो RML हॉस्पिटल से हैं, डॉक्टर रमेश अग्रवाल जो ऑल इंडिया इंस्टीट्यूट ऑफ मेडिकल साइंसेज दिल्ली से हैं, और डॉक्टर नीरज गुप्ता जो कि ऑल इंडिया इंस्टीट्यूट ऑफ मेडिकल साइंसेज जोधपुर से हैं। तो हम अब टेक्निकल सेशन शुरू करेंगे, जिसमें मैं सबसे पहले इनवाइट करूंगी डॉक्टर नीरज गुप्ता को, जो बात करेंगे पेरीनेटल एस्फिक्सिया पे। क्योंकि देखिए, बच्चों की, नवजात शिशु की मृत्यु के लिए यही इंपॉर्टेंट कारण है, सेप्सिस है, एस्फिक्सिया है, प्रीमेच्योरिटी है। तो ये तो ब्रॉड चीजें हैं, जिनमें जो स्पेसिफिक्स हैं उनको हम डील करना चाह रहे हैं। तो आज सबसे पहले पेरीनेटल एस्फिक्सिया पे बात करेंगे डॉक्टर नीरज गुप्ता, हु इज एडिशनल प्रोफेसर इन नियोनेटोलॉजी एट एम्स जोधपुर, और इन्होंने अपनी DM की शिक्षा प्राप्त की थी PGI चंडीगढ़ से। ये हमारे बहुत बढ़िया रिसोर्स हैं, एक काफी डिपेंडेबल हमारे एक्सपर्ट हैं, जिनको हमने आज बुलाया है, जो आपसे डिस्कस करेंगे पेरीनेटल एस्फिक्सिया के बारे में। डॉक्टर नीरज, प्लीज, द फ्लोर इज योर्स।
Thank you, ma'am, for kind introduction, and a very good afternoon to all of you. आप सभी को मेरा नमस्कार। First of all, I would like to thank Ministry of Health and Family Welfare, especially Agnani sir, Ghosh madam, and Dr. Kapil for giving me this opportunity to be in front of you and to share my view on perinatal asphyxia, and being a major problem, how by what simple ways we can improve the outcome of these babies. So the first question is that why we want to discuss about this problem. I think the figures which are shown here are very much glaring. If we see the causes of neonatal mortality as pointed by Agnani sir as well as Ghosh ma'am, so almost we are touching that 20% of the cases of neonatal deaths are because of asphyxia, though the latest figures are little less, maybe around 13 to 14%, but this is a major chunk. अगर हम 1/5 बच्चे अपने न्यूबॉर्न्स एस्फिक्सिया से लूज कर रहे हैं, तो इट मीन्स कि ये एक बहुत बड़ी बात है और हमें यहाँ पे फोकस करना है। एंड द प्रॉब्लम हियर इज दैट द स्टोरी डजंट एंड हियर. If we see the causes of stillbirth, the half of the stillbirths takes place during the intrapartum period and half occurs before that. And most of these stillbirths which are taking place during the intrapartum are because of intrapartum asphyxia. तो यदि हम इन दोनों को मिला दें, the neonatal mortality because of asphyxia as well as these stillbirths which are primarily because of intrapartum asphyxia, so probably this may become one of the topmost causes of your neonatal mortality. Now, looking at the various figures which are available, if we see from the community-based studies, the incidence of asphyxia has been reported to around 2 to 16% with a fatality almost like 40 to 70%, which is a huge. Though this data is little old from the gut chirology studies, And if we look at our NNPD database of 2002-3, from the hospital-based studies with whatever definition they have used, this is varying from 3 to 6% with a case fatality touching around 10%. So it means that this is a big problem for us. And the problem, next slide, please, Dr. Kapil. The problem doesn't end here. This is another major issue, that those babies who are surviving, almost 1/3 of them have neurodevelopmental sequelae. And this sequelae is not only in form of cerebral palsy. If we see, they have all set of disease problems, including vision problem, including hearing issues. They have low cognitions, low IQs. They need more special attention. They have behavioral issues, ADHDs, and all that. So which means, though these faces looks, they are smiling, but these smiles really haunts us. That what are we doing? What are we doing? Are we doing the right things? I think we need to introspect ourselves. So our aim is that we need to have intact survival, but are we going to achieve that? We are faltering on both the levels, both in terms of survival by causing a lot of mortality, as well as in achieving that intactness because of a lot of sequelae. So I'll be just focusing on the two basic aspects, that what is perinatal asphyxia and how we can optimize the management of perinatal asphyxia. So before I go to the definition, we commonly use a lot of terms. So let me just spend 1 minute to demystify these basic terms. Commonly we use the word hypoxia. Hypoxia means lack of oxygen, whether at tissue level or in the blood. In the blood we use called hypoxemia. So agar oxygen kam hai, that is called as hypoxia. Asphyxia and hypoxia sometimes are used interchangeably, but they are not so. Asphyxia means it is not only hypoxia, but there is CO2 retention also. So there is hypercapnia. So which means, because of the gas exchange doesn't take place at the uteroplacental level because of any reason. Let's say it was a high risk pregnancy, there was placental insufficiency, there was hyperstimulation of the uterus because of oxytocin, which causes retention of CO2 and less of oxygen in the fetal blood, leading to issues. So that is asphyxia. Ischemia is another term which we commonly use. Ischemia means that the blood flow is less. Blood flow to any organ is less. And when we talk of blood flow, it is not only going to decrease the supply of oxygen to the tissue level, but it is also going to decrease the supply to the substrate, which is glucose, the glucose which is going to that tissue level. When you have a combination of both hypoxia and ischemia, that becomes hypoxic ischemia. And when it affects the brain, causing some changes in the sensorium, in the tone, which is called as encephalopathy. And this encephalopathy, because of this hypoxia and ischemia, is labeled as hypoxic ischemic encephalopathy, or HIE. Next slide, please. So people have used different definitions of perinatal asphyxia. We don't have a uniform definition. If we look at the standard definition by World Health Organization, it simply says failure to initiate and sustain breathing is perinatal asphyxia. कि कोई बच्चा पैदा हुआ, ना तो वो सांस ले पाया, या उसने सांस लेना शुरू किया लेकिन वो सस्टेन नहीं कर पाया. This is a very simple definition which can be used in the community, though this is a very sensitive definition. A lot of babies may qualify, which actually may not be. The second most common definition which is used is what is given by National Neonatal Perinatal Database, NNPD, which divides it into moderate and severe perinatal asphyxia, which says at 1 minute of age, if the infant is having gasping efforts or slow efforts, or if we have the Apgar scores which are available and they are between 4 to 6, then it is called as moderate asphyxia. Whereas if the baby is not breathing at all at 1 minute, or the Apgar scores are between 0 to 3 at 1 minute, it qualifies for severe asphyxia. This is again little sensitive definition, but if we look at the definition which was given way back by AAP and American Academy of Pediatrics and American College of Obs and Gynae, it is a very stringent definition, very specific definition, primarily for the medical legal aspect, which says that all the following 4 parameters or the criteria should be there. The first is that there is an evidence of acidosis, whether it is metabolic or mixed, if defined by the cord blood, which often is not available in most of the settings, especially in level 2. Then there has to be low Apgar scores, which is less than 3 at 5 minutes of age. There has to be evidence of neurological dysfunction as well as organ involvement. So all the 4 should be present to qualify. So if we see that the definition by WHO and NPD is more sensitive so that you can take a decision immediately and start treatment, where this is much more specific. By and large, the Indian data is based on this NNPD definition. Next slide, please. Next slide, please. Next slide, please. Okay. So once a newborn suffers asphyxia, it is important to understand that all the body systems are involved. It is not only the brain, though the focus is primarily on the brain, but it is all the body systems which are involved. And it is important to know that because of two reasons. One is that we need to monitor these systems. It is the heart which is involved, which may manifest in form of metabolic acidosis or shock. The lungs may be involved, causing respiratory distress. Your liver causing initially some derangement in the LFTs, liver function test, and may cause coagulopathies. Kidneys may get affected, the urine may not be formed, the waste product may be getting accumulated, hematological and GIT. So it is important to understand that these systems needs to be taken care along with the CNS. It is not only that we have to focus on the CNS. And moreover, if we don't optimize the treatment of all these systems, your brain will not recover well. So for both these reasons, it is important to understand that all these systems needs to be addressed. And for CNS, for grading encephalopathy, one can use the simple classification which only has 5 parameters focusing on the level of consciousness, whether how is the tone, whether the baby is having seizures or not, how is the suck reflex, and how is the breathing pattern. Based on these 5 basic parameters, which can be judged very easily by anyone at any health facility level, one can qualify that whether this encephalopathy is mild, moderate, and severe. The reason to classify is that we know that the chances of mortality as well as morbidity is much higher in the severe category as compared to the mild category. And the treatment modalities may change for moderate and severe in terms of therapeutic hypothermia, where the facilities are available. Next slide, please. But when it comes to the management, when we encounter these babies and we see that the baby has suffered asphyxia, तो दिमाग में आता है कि अब तो कुछ नहीं हो सकता. We can't do anything for these babies. Friends, we need to remember that excuses are the nails which are used to build a house of failure. So what we need to do is we need to identify the strengths and then those strengths which are doable and which are going to improve the outcome. So we need to leave this attitude and a lot can be done in the management to improve the outcome. So this is a little busy slide. So let me just focus on the left part of the slide to understand the optimization of the management. So typically what we have a high risk pregnancy where the mother is having, let's say, pregnancy induced hypertension, or there is fetal growth restriction. And on top of that, some sentinel event like abruptio or hyperstimulation of the uterus because of oxytocin takes place, which leads to an event which is called as perinatal asphyxia or hypoxic ischemic injury to the brain. Because of this lack of oxygen, the ATPs are not produced and the cells swell up, the sodium potassium pump, they don't work, and the cell necrosis takes place, causing the brain injury immediately. And at this point, the obstetricians try to deliver the baby as early as possible, and the baby is born, and we try to resuscitate. Once we try to resuscitate, a lot of this hypoxia which was taking place or asphyxia which was taking place is taken care during resuscitation, and the changes which have taken place, they start getting resolved. And then the second part of the injury which starts taking place because of the various reperfusion parameters, the various free radicals and various mediators which are released, which causes secondary energy failure by affecting the mitochondria and causing further neuronal death. So if we focus on this, the primary energy failure can be taken care only by the preventive strategies, which as well as the prompt recognition. But what is in our hand is how to optimize this treatment by doing proper resuscitation and giving proper post-resuscitation treatment. And when we talk of treatment in terms of optimization, we need to remember this basic principle that we have to prevent the further brain damage, the damage to the neurons which can happen here because of the secondary energy failure. And second is how we can revert whatever the damage has taken place by instituting therapy which is called as therapeutic hypothermia, which is for moderate and severe. So my talk will be focusing on the preventing further damage, the basic principles of management, which is available, which all of us should be aware. And it is equally important to understand these basic principles needs to be followed right immediately after birth in the labor room, and needs to be continued during transport, whether it is intra or interfacility transport, and followed by the subsequent management of this baby in SNCU or neonatal ICU. Next slide, please. So coming to the labor room management, that is resuscitation, all of us are aware that 90% of the babies doesn't need any kind of resuscitation. Among those 10% also, it is only the less than 1% required chest compression drugs, which means 99% of our needs are taken care by these basic things, that is initial steps and positive pressure ventilation. So if we are trained enough to focus on these two things, if we can deliver or do these two steps, that is initial steps in effective PPV, I think the job is done. Next slide, please. So it is very important that we need to identify the high-risk pregnancies, but simultaneously we need to remember that almost 1/5 of these high-risk, in the pregnancies, they may not be a high-risk factor, and still the baby may suffer perinatal asphyxia. And that's why it is very important that at the point of delivery, the person who is attending the delivery, that person, whether a doctor or nursing staff, should be trained in neonatal resuscitation. And for that, we need trained personnel. All of us undergo training, but it is a good idea to refresh that, to do simulations in the respective settings, to see are we up to the mark or we need to further improvise ourselves. Often we find that the personnel is available, but either the equipment is not available, or even if it is available, it is not in the working condition, which causes a delay in the start of resuscitation. So it is a good idea that we have a checklist so that it becomes easy for everyone, that if the supply is not available, one can replenish that supply and the things are available in a working condition at that time. Next slide, please. So getting meconium staining in these cases is not very odd. A lot of times we get a combination, there is a meconium stained amniotic fluid and the babies are asphyxiated. So as highlighted in 2015 guidelines, and the same has been reiterated in 2020 also, that the babies who are born with meconium stained amniotic fluid and are non-vigorous, which means they are not breathing at birth, there is no role of routine intubation, which used to be done 10 years back. Because when you are intubating these babies, you are losing the precious times to resuscitate, to start positive pressure ventilation. So there is no point, no role of routine intubation and tracheal suction, even in non-vigorous babies. No question for vigorous babies at all, but even in non-vigorous, there is no role. So in these babies, even they are non-vigorous, one need to start with the initial steps, followed by positive pressure ventilation if required. Why positive pressure ventilation? If one finds that the chest is not rising, then it means there is a possibility that the airway may be blocked because of meconium. Then it makes sense to do suction, otherwise not. Next slide, please. Another important thing while giving positive pressure ventilation during resuscitation is to note that what percentage of oxygen we are using to deliver this positive pressure ventilation. A simple strategy that starting with room air instead of oxygen can decrease the short-term mortality by almost 27%. So which means all these babies, when late preterm and term babies, if PPV has to be given, positive pressure ventilation has to be given, one need to start resuscitation with 21% oxygen, but not 100% oxygen. So it is very simple. You don't have to attach any kind of oxygen to your self-inflating bags. Whatever is coming is air, which is 21%. You start with that. If the baby is not picking up, or if you have the facility for pulse oximeter to check preductal saturation, then you can increase FiO2. Those who have the blenders, they can use blenders. If the blenders are not available, then you can just attach the oxygen, which is attaching oxygen without reservoir is going to increase the FiO2 from 21 to almost like 40-45%. And then even if the baby doesn't improve, then you can attach a reservoir. So the bottom line is that please start resuscitation, positive pressure ventilation with 21% oxygen, but not with 100% oxygen, which is going to cause more and more damage. If the facilities are there for pulse oximeter and blender, I think then you are blessed, and that is the forward. But if you have to give chest compressions, then please switch over to 100% oxygen. Next slide, please. Now, after resuscitation, coming to the basic principles of management, though these 4 words TABC looks very simple, but friends, let me remind you that these are the very basic principles which needs to be followed in each and every case, and more so when you are talking of perinatal asphyxia. Next slide, please. So coming to the temperature, that is T. We often find, we know that there is some role of therapeutic hypothermia. So often sometimes we end up in switching off the radiant warmers and try to decrease the temperature. If the facilities for therapeutic hypothermia is not available, which is the case in level 2 SNC, which is not available, so please avoid uncontrolled hypothermia. That is uncontrolled hypothermia which has to be avoided, because you are trying to decrease the temperature by thinking that will be causing more good because there is some evidence of therapeutic hypothermia. But remember that hypothermia we are talking is in a controlled environment, in a controlled way, in a protocolized way. If we don't have the facilities, one should not attempt that. Previous slide, please. Similarly, we should avoid any kind of hyperthermia, because hyperthermia also causes brain damage. So it is very important that the temperature needs to be maintained between 36.5 to 37.5 degrees Celsius right from the labor room and during transportation till the point the baby reaches NICU. Next slide, please. Now coming to the airway and breathing. Often these babies have hypotonia, which causes the flexion of the neck. So if the neck is flexed, they will not be able to breathe properly. So it is a good idea to use shoulder roll in a lot of these cases. Remember that it is a shoulder roll. It is not head roll, unlike which is used in your pediatric and adults. If you put head roll, rather the neck is going to be more flexed, which is going to compromise the airway. And because of the bulbar or pseudobulbar palsy, a lot of these babies have pooling of secretion. So it is important to take care of these secretions by doing regular suction. But it doesn't mean that unnecessarily we keep on doing oro and nasal suction, because that is going to cause more harm. But if secretions are there, they are compromising airway, then yes, it needs to be done. Regarding breathing, if the babies have minimal respiratory distress and the respiratory drive is intact, then in these babies you can start continuous positive airway pressure. But if the respiratory drive is not intact, then your CPAP is not going to work. In these cases, you need to intubate and go for invasive ventilation. Next slide, please. Now coming to the oxygen. Again, 10 years back, we used to think that oxygen is like a Ganga Jal or Amrit. But I think our understanding about oxygen has improved a lot. Hats off to Ramji sir, Dr. Saukstad, and these stalwarts who clearly defined that how oxygen can be detrimental. So we need to understand that oxygen on one hand can be Amrit, but on the other hand, it can be Vish. So it is a double-edged sword. If your babies are hypoxic, hypoxia is also going to cause more and more damage by causing pressure passive, increasing the pressure passive circulation, which is there in these babies, and causing more and more brain damage. Whereas if you look at the other side, that is hyperoxemia, if we give more oxygen, because we have tendency that the baby had suffered asphyxia, so the oxygen is less, so why not to give more oxygen? But this oxygen which you are going to give, it is going to create more free radicals, going to cause more cerebral vasoconstriction, which is going to damage and more brain. It has been found that severe hypoxia can worsen the outcomes, neurological outcomes, by almost 4 times. So friends, remember that all asphyxiated babies, they don't need oxygen. Both hypoxia and hyperoxia is detrimental. Try to maintain their saturations between 90 to 95%. If the saturations are low, you need to give. If the saturations are normal, then there is no point in giving unnecessary oxygen. Next slide, please. What about ventilation or carbon dioxide? So again, something like oxygen here, if the body has less carbon dioxide or more carbon dioxide, it is going to be detrimental for the brain. Less carbon dioxide, which is hypocarbia, will cause constriction of the blood flow and the vessels, and it is going to cause ischemia. And it has been found that those newborns who have severe hypocarbia, again, the neurological outcomes are bad. Similarly, if you have hypercapnia, because of the poor ventilation issues, the drive is not intact, it is going to cause sudden increase in the circulation, which can cause hemorrhagic infarct. So the bottom line is that if the baby's drive is not intact, the baby is hypoventilating, please intubate this baby. But when you are intubating, remember that when you are ventilating, don't do overzealous ventilation, because when you do overzealous ventilation, you will cause hypocapnia. So previously you are not ventilating, so you were causing hypercapnia, which was causing damage. Now you have intubated, you are doing ventilation, but you are over ventilating, so you are causing hypocapnia, which is going to be detrimental. So remember those 3 magical words: breath, 2, 3, breath, 2, 3. So if you provide ventilation by saying breath, 2, 3, you will be able to deliver the right respiratory rates. Next slide, please.
Dr. Neeraj, we have about 5 minutes more.
Sure, madam, sure. So coming to the fluids, I would say that don't restrict the fluids routinely. Restriction of fluids is more detrimental. It has shown more adverse effects. So next slide, please. Fluid restriction has a very specific role. Next slide, please. So fluid restriction has a very specific role in those cases where you are suspecting syndrome of inappropriate secretion of diuretic hormone, or the babies have heart failure because of myocardial injuries or renal injuries. Only in those cases you have to restrict fluids, otherwise fluids should not be restricted. What about blood pressures? Similarly, the babies who have low blood pressures or high blood pressures, they have more complications. So remember that if the facilities are available through multi-para monitors, please monitor the blood pressures and try to target mean arterial pressure at least more than 45, with systolics around 55 to 60 in term babies. Next slide, please. Coming to the inotropes, we don't have much evidence. So whatever is available in your system, if the baby has hypotensive, please use that, but make sure that you don't use routinely dopamine on all these patients. Next slide, please. What about sugars? Very important. A simple intervention which can change the outcome. Babies who are asphyxiated and have hypoglycemia, their neurological outcome is almost 18 times poor. So by simple maintaining sugars between 50 to 100 by regular monitoring, you can prevent a lot of brain damage. But simultaneously, you need to prevent hyperglycemia also, because this will also be detrimental. Next slide, please. What about seizures? Seizures is a very common problem. Almost 50% of these babies have. So should I start prophylactic phenobarbital in all the babies? The answer is no. No role of prophylactic phenobarbital. Do I need to treat all seizures? Yes. Once you have clinical seizures, you need to treat, because recurrence of these seizures per se causes brain damage. So what to do if the baby throws seizures? Remember that whatever you manage, ensure that the first principle is TABC. And after that, you need to first correct hypoglycemia and then calcium. Don't directly jump on phenobarbital without checking sugars and calcium. Otherwise, you'll keep on giving phenobarb and the baby is hypoglycemia and he'll keep on throwing seizures. Next slide, please. So what should be the first anti-epileptic drug? The first drug remains phenobarbital. A lot of drugs are being tried nowadays, but still, whatever the current evidence is, it says phenobarbital. So don't go for Levera or topiramate as the first drug. Please use phenobarb. And then once you have exhausted that by 20, 10, and 10, then you can think of adding second drug, that is phenytoin. And once you have given, try to taper these drugs as early as possible, because these drugs per se causes apoptosis and more brain damage. Next slide, please. What about cerebral edema? Cerebral edema is very common, but remember that it is a marker of damage. So there is no role of the typical drugs like mannitol, furosemide, or steroids, which we commonly use in the adult population or pediatric population. Please do not use these drugs in neonatal population. Next slide, please. What about kidneys? Kidneys need, a lot of things needs to be monitored, like urine output, weight gain, electrolytes. But as I said, there is no role of routine fluid restriction. Fluid needs to be restricted if the baby is having abnormal weight gain or baby showing signs of renal failure. And if the baby has already gone into intrinsic renal failure, then of course you need to switch to anaerobic regime and then refer this baby for the peritoneal dialysis to level 3 facility. Next slide, please. What to monitor? I think we have a wonderful monitoring sheet in and the basic remains same, that we have to monitor the vitals, and the monitoring has to be all system related. As I said, that it is multi-system involvement. So CNS status, cardiovascular through heart rate, pulses, CFT, saturations, blood pressure, respiration by Downey's and saturations, and GIT by girth and bowel sounds. Please do not forget to check regular blood sugars. Next slide, please. So this is the monitoring chart, which all of you are aware, which virtually covers most of the parameters which we need to monitor. Next slide, please. Next slide, please. When to start feeds? Once the babies are stable and there is no distension with good bowel sounds. Remember that don't keep on waiting for the passage of stool. It will be too late. If other two parameters are okay, please start feeds. Start at 30 ml per kg per day and then keep on increasing based on the tolerance. Next slide, please. So it is very important to prevent infections, because infection per se causes mortality, and even if the baby survives, there will be a lot of morbidities. And we need to start early interventions by involving the family, doing KMCs in low birth weight babies, clustering of activities, starting gentle exercise for their improvement. And next slide, please. So we have very good guidelines for district early intervention centers. So this is a holistic thing. So unfortunately, even in level 3 facilities, we are struggling for this, but I think that is a way forward, which Agnani sir was also saying, that the 6th pillar which we have been added is care beyond survival. So these district early intervention centers are the way forward to improve this care beyond survival, where holistic care for assessment of development, anthropometry, speech therapy, audiological, occupational therapy can be given to these babies for improving their outcomes. And if the baby needs invasive ventilation, or the shock is not responding, has refractory seizures, or had gone into renal failure, then of course we need to refer this baby to level 3 facility. But remember that, next slide please, that the basic principles of transportation needs to be ensured. We need to stabilize by maintaining their temperature, oxygen, sugars, and perfusion, and the same has to be continued during transportation and after that. Next slide please. Of course, the best is prevention for each and everything, and already highlighted we have multiple programs, education is required. Next slide please. So I would just like to highlight that this is a drug which is often misused, that is oxytocin. So please sit with your obstetric colleagues, have a cup of tea with them, and tell them that this is not a drug which can be used, which should be used routinely. And a lot of things can be managed by taking care of that. And of course, the monitoring in the interpartum period is very important. So I will conclude by saying that we need to improve the quality of care and leave this attitude of chalta hai. Once we focus on these basic principles, we'll be able to achieve much more. And best is that we can anticipate and prevent this perinatal asphyxia. Thank you very much for your patience listening.
Thank you, Dr. Neeraj, for a very lucid presentation, and you tried to simplify many issues related to how to manage a baby who's asphyxiated. So friends, I'm getting requests repeatedly saying that talk in English, and then others saying no, talk in Hindi. So we will try and do our best to see how best we can address both aspects. So Neeraj has really talked about what is asphyxia, and he says if the baby doesn't breathe at birth, that is very sensitive definition. That's true. If the baby doesn't breathe even at 1 minute after you've done your initial steps and you've started doing positive pressure ventilation, that blends both specificity and sensitivity. So agar 1 minute tak bhi, by 1 minute also, if the baby is not started breathing on his own, he certainly is a baby who requires positive pressure ventilation, who is truly asphyxiated, as he has told you. So it's absolutely clear that all organs are involved. But if you don't take care of other organ involvement, then the brain is going to take the hit ultimately. You will not have a baby who has chronic renal failure or chronic some other failure, but you will have a baby who survives and has sequelae related to the brain. So it's important, ये जरूरी है कि हम बाकी सारे organs की जो भी दिक्कत हो रही है उसको ठीक करें, और तभी बच्चे का दिमाग जो है या brain injury बिल्कुल minimize हो पाएगी. There are many questions related to endotracheal intubation and room air and all. So very simple to say, or very clear to say, that endotracheal intubation in non-vigorous meconium stained liquor is not advocated. This is based on some research that has been done, and you would be happy to know that most of that work, or in fact all of that work, has been done in our country. Similar to room air resuscitation, which again Dr. Ramji from our country has worked on that. Blender, he has very nicely explained you. If you don't have a blender, don't worry, don't say that हमारे पास तो blender नहीं है, हम क्या करें? You can use a bag without any oxygen, 21%, with oxygen attached, close to 40-50%. So you can work even without having a blender, although it is ideal to have a blender in the birthing area. The last thing that has been emphasized very well is you have to maintain everything in the normal range till the baby recovers. Normothermia, normooxia, normal carbon dioxide, normal sugar, and so on and so forth. And also normal perfusion. If the baby goes in shock, or if the baby has high blood pressure because of you using inotropes, which is not required, the baby is going to have bleeds in the brain. So the questions that are related to oxygen therapy, somebody has asked about oxygen therapy. Let's listen to Dr. Ramesh, then we can come to that if there are still questions remaining related to that. EEG, somebody has written, we don't have EEGs. I don't think all of us also have bedside EEGs anywhere in the tertiary care center. You don't need EEGs to decide on when to stop seizure treatment. Because in asphyxia, the seizures are only till the time there is hypoxic ischemic encephalopathy, which is the first 72 to 96 hours. After that, they will die down on their own because the asphyxia process, then it is only the sequelae. So we really don't need EEG to decide when to stop anticonvulsant therapy. So I think without wasting any further time, we will answer your questions in the chat box. Let's go on to the next topic, which is very important, which is respiratory distress in neonates. And for all of us to understand, maximum babies in any SNCU or NICU are the ones who have respiratory problems. So this is a very important topic, and we need to understand in detail how to recognize this and how to manage this. For this, we have Dr. Ramesh Agarwal from All India Institute of Medical Sciences. He is professor in the Department of Pediatrics, and he has done his DM from AIIMS. So he is a qualified neonatologist talking to us on respiratory distress in a very simple manner. Dr. Ramesh, floor is yours. Dr. Ramesh, please unmute yourself.
Yeah, thank you, Dr. And Kapil, just wait before you start the video. And greetings from my side. I see 2,000 old people sitting in this afternoon. Dr. Sushma, I'm attending. This is the first webinar for me where 2,000 participants are there. Amazing, and thank you very much. Thank you, Dr. Agnani, and then thank you, Dr. Ghosh, for organizing this wonderful opportunity. Dr. Kapil, thanks. And the people who are sitting are, I wish to tell that we are very proud of each one of you. And in this difficult corona time, the way the medical fraternity and then the healthcare provider in general have hold the forte, it's absolutely amazing. And the job that you have done at the remote places in all the adverse environment, it's absolutely amazing. And I wish and pray that you stay safe and be happy and continue to do what the good work that you are doing. So my talk would focus on respiratory distress syndrome, respiratory distress in neonates. And as Dr. Sushma just now said, that approximately 30% of the babies would get admitted, that are admitted in our SNCUs have respiratory distress. So respiratory distress is a clinical sign that is characterized by fast breathing, chest retractions, grunting, and cyanosis. So varying combination of all these factors. Term babies have respiratory distress and preterm babies have respiratory distress. There are multiple causes. And but I think the most important thing for us to understand is that when you manage these babies, there is a simplified approach wherein when we will approach each and every baby irrespective of the cause and manage these babies. And what is the cause is not as important, because the initial management and in fact majority of the remaining management is the same. So it's sort of a syndromic approach. So before I go on to this lecture, I would like you to see this baby. Kapil, please switch it on to see this video of 30 seconds of a low birth weight baby who's having respiratory distress. Kapil, please. Okay, so I'm quite sure you noted that this is a small baby, preterm low birth weight baby, was having difficulty in breathing, There was lower chest retractions, and there was suprasternal retractions also. And you can see that there was a catheter, that there is a nasal catheter was there to deliver the oxygen, and baby was making a distinct sound, which was a prolonged expiratory sound, which is known as grunting, which signifies that the baby has got significant amount of respiratory distress. Okay, next slide, please. So what do you do when you when you encounter such a baby in your emergency or in your delivery room or wherever? Dr. Neeraj just talked about TABC. I think this is the main mantra, and it is really very important that whatever the problem is, be it a respiratory distress, or be it a seizure, or be it anything, you assess the baby in terms of TABC and manage TABC. I'm quite sure you know the meaning of each one of them. T stands for temperature, A for airway, B for breathing, and airway breathing both go hand in hand, and C is circulation. So these are very important principles. Whenever you encounter a sick baby, always assess TABC and manage TABC before you go on to anything else. Next, please. Okay, so coming to T. So when you have a baby who has got respiratory distress, that means this baby is a sick baby. So you need to shift this baby to your neonatal unit, put the baby in the radiant warmer, and use the servo control mode and set a temperature of 36.5 to 37.5, and check the auxiliary temperature. And of course, if the baby is hypothermic, then this baby requires extra heat. Next slide, please. So it is therefore really very important to make sure that the baby is warm enough. The second component is airway breathing, that we assess breathing. And if this point we find that some of these babies came in respiratory distress, and by the time you brought them to the radiant warmer, it is possible that they have now developed feeble breathing or gasping, or they are not at all breathing. So these are the babies that should be resuscitated with positive pressure ventilation. We connect these babies to pulse oximeter, and depending, because this baby has got respiratory distress and possibly hypoxemia and cyanosis, so therefore you need to provide this baby with adequate respiratory support. So when we say the adequate respiratory support, there are two important factors that come into picture. One is, what is the gestation of the baby, whether the baby is term baby or late preterm babies, that means the mild degree of prematurity, or the baby is severely preterm. So one is gestation. The other is what is the degree of distress. So you may have baby who has got just a mild tachypnea and some amount of retraction. I have just labeled it as some distress, though you will not find this term, but I thought that this makes sense, that we label these baby with some distress, right? Or you may have baby whose breathing rate is very fast and then retraction is very marked. The baby is grunting, baby is cynos. That means there is significant amount of distress, right? So if it is a term baby or a late preterm babies, that means the babies who are more than 1.8 kg, more than 34 weeks of gestation, then if they have some distress, you can put the baby on oxygen by hood or cannula. If the baby has got significant amount of respiratory distress, then these babies should be put on nasal CPAP, right? If you have a preterm baby who's, let's say, less than 1.8 kg and less than 34 weeks, and these babies have some amount of distress, then oxygen by cannula is not a good choice because they have pliant chest wall. Therefore, some distress is better managed by HFNC, high heated, high flow, and humidified nasal cannula. I don't know, some of the units may have this device, or some of them may not have. If they don't have, then these are the babies that would be managed with CPAP. And of course, if you have significant amount of distress, next slide, please, Kapil, then these babies should be managed with nasal CPAP, right? So let's look at the oxygen therapy, that means free flow. And we just talked about that the babies who are more than 1.8 kg and more than 34 weeks and with some amount of distress, then we can deliver this oxygen using nasal cannula. And this is a simple tube, and I'm quite sure you use it quite often. You put the baby in the baby's nostrils and fix it on the head. What is important to realize here is that this is a low flow device. And what does that mean? That you cannot give a flow which is more than 0.5 to 1 liter per minute of oxygen. And there is no need for humidifying this oxygen when you are giving this much of flow by a nasal cannula, right? And this particular thing would only provide maybe 30% or 40% of oxygen. So if the baby requires too much of oxygen, then this device is not going to work in the baby, right? Then you might have to go to the next level. No, just go back, Kapil. And then the second device is the head box, or the hood as you call them. And these are the device which is relatively high flow. And what do I mean by that? That here you can have 2 to 4 liter per minute of oxygen can be connected. Again, there is no need for humidification, but because this is a closed space, so therefore you would be able to achieve a higher FiO2 concentration, meaning higher oxygen concentration to the extent of 60 to 70%. So if a late preterm baby or a term baby has got some amount of distress, then these babies can be managed by nasal catheter. But if they require higher concentration of oxygen, then this baby can be put on head box. Next. The second level of support is what is known as heated, humidified, high flow nasal cannula, right? So the name is very long, but the device is very simple. And some of your units would have it, or I mean, the units are likely to get such kind of devices very soon. And what are these? So you can see that here you have a flow meter, and in the flow meter you have air oxygen flowing in at a desired concentration of oxygen. You can set it at 30%, 40%, or 50% as you need them. And then this will be going to the humidifier, which will heat it and humidify it, right? This is the water bottle that is filling the humidifier. And from here, you would have a single tube that is going to the baby and is connected to a cannula, which is known as high flow nasal cannula, right? So you connect the baby with high flow nasal cannula, you would have 2 to 5 liter of flow that is going to the baby and would provide oxygen and some amount of respiratory support. So this is the next level of support that can be provided to babies who are less than 1.8 kg and less than 34 weeks with some amount of distress. Next slide, please. The next level of support is what is known as continuous positive airway pressure, that is CPAP. And I'm quite sure you know about it, and not only you know it, but you love it. I'm quite sure about that, because this can be used with significant amount of respiratory distress in preterm babies, though it is not so much recommended in term babies, but still you can use it, right? So what is happening here, as we saw in the last slide, the initial part of setup is the same only, that you would have oxygen and air flowing into the blender, and then you set the oxygen concentration, and then that goes into the humidified gas, and then it goes into the this circuit, right? And on this circuit you have a cannula that is attached to it. So while the majority of the gas flow occurs at a rate of 4 to 6 liter per minute in the circuit, and it escapes from the expiratory end, which is dipped into the water, and depending upon the length that is dipped in the water, it would generate a pressure here, which is known as your CPAP, right? So it is sort of a side stream of flow, right? And therefore you want that the cannula is a proper CPAP cannula. In the earlier example, you only had one tube here. So whatever the flow you were releasing, and I talked about 2 to 5 liter per minute, everything would be going into the baby. And this fact is very important because I mean, because of this fact, your CPAP cannula and your HFNC cannula are different, and they cannot be used one in place of the other. Next slide, please. Right. So we were talking about the cannula. You can see this is the HFN, this is CPAP cannula. So this is CPAP cannula, which is a Hudson type. And this is the most common form of CPAP cannula that is available. You have oxygen air that is humidified and heated coming from here, that flows from here and gets out of from this tube into the water column, and in that process it generates pressure. And then you have binasal cannula. These are short cannula. So therefore, in order to have that pressure transmitted to the baby, you have to have a cannula which is snugly fitted, right? Snugly fitted, but not so fitted that it causes injury. CPAP injury is a very common thing. So therefore, you have to make sure that the CPAP cannula is of appropriate size and it is fixed well. And you need to observe in each and every shift to make sure that it is staying and it is not causing any injury, right? As opposed to this cannulas, HFNC cannula is different, right? So you have the air oxygen mixture connected from this end, and then from both the sides, the air oxygen would be coming and getting into the nostril. And if you release, let's say, 3 liters per minute of oxygen air into the baby's lungs, and if there is no way to escape this extra air, the baby's lungs would be blown up. So therefore, the HFNC cannula should not be snugly fitted, right? So it should only occupy maybe 1/3 of the area, so that the extra air can escape into the environment. So that is the basic difference between CPAP and HFNC cannula that you should always remember. Next slide. Okay, a small proportion of the babies would require mechanical ventilation. And who are those babies? The babies who were apneic and gasping, and even after positive pressure ventilation, they stay apneic. Or if you have severe distress that is unresponsive to your CPAP therapy, or remains cyanosed or low hypoxemic despite non-invasive support, or if the baby has got shock or hemodynamic instability and is not responding despite your fluid bolus or initial management. So these are the babies who would require to be shifted to tertiary care hospital. But the good thing is that only a small fraction of the babies would require this kind of support. Majority of the babies you would be able to manage at your SNCU. Next slide, please. Right. So we talked about airway and breathing. Now let's come to the third component of TABC, fourth component, and which is the C. So you need to check the hemodynamic instability or presence of shock. And I think it is very, very important that whenever you approach a baby, you assess the baby for hemodynamic instability also, so that you identify timely identification is very, very important, that the baby has or does not have any shock. So what are the evidence of shock? Like high or low heart rate, right? You can have a baby who's pale or cyanosed or mottled. You may have cool periphery. You palpate the radial pulse, and then you find that the pulses are hardly palpable. You see capillary refill time and you find that it's greater than 3 seconds. 1, 2, 3, 4, 5. You press it for 5 seconds and then release it. 1001, 1002, 1003. And even if the capillary refill does not return, that means it's a poor capillary refill time and baby may have shock. So these are the babies who should be, after stabilizing TAB, now they should get treatment for shock in form of normal saline bolus, 1 or 2. And if they do not respond, then we might have to start these babies on dopamine. Next slide. Okay. You see that we are almost midway through our presentation and we haven't talked about the cause of the respiratory distress. And again, I would like to emphasize that it is important to know the cause of the respiratory distress, but it is also important and perhaps more important to manage the baby first. First, you take care of the things that are to be taken care for all the babies in a similar fashion, and then you come to the other issues. So now at this point, after having managed TABC, you need to assess whether the baby requires surfactant, and this medicine is now available at SNCU. Therefore, I'm talking about it, that you first make the judgment whether the distress could be due to respiratory distress syndrome and baby may require surfactant. And who are these babies? These babies are often less than 35 weeks of gestation. They have conditions that can result into development of RDS, like mother did not receive antenatal corticosteroids. Less than 32-week babies are much higher risk. Mother is diabetic, asphyxia, sick. So if you have a combination of these factors, then you know that the baby is at high risk of RDS, and you find that the baby has developed distress soon after birth, and which is increasing in severity and is requiring oxygen for 40% or more, even on CPAP, then these are the babies who are likely to be surfactant deficient, and then you need to give surfactant replacement therapy. You can look at chest X-ray, but chest X-ray is not mandatory because that would unnecessarily, next slide please, that would unnecessarily delay surfactant therapy, which is more effective if you give it on time. So what is the different? You are different preparation, but very often Cervanta is available at majority of the SNCUs, and you give 4 ml per kg in 4 aliquots. I'm not going to discuss about the methods of administering surfactant. Important is that when you intubate the baby, make sure that your ETT is in proper position. So if your ETT is outside, the surfactant would go in the stomach. And if it is too far in, then it would go in one lung, and then that would cause harm to the baby. And for the dispersion, when you are ventilating the baby, be gentle. There is a tendency that when you have bag in hand, you are providing too much of pressure, and not only too much of pressure, but delivering the positive pressure at a very high rate. So I think you need to be very gentle, not too much of pressure, and then the rate also, right? And now assess, once you have given surfactant and if the baby is breathing well, then you can extubate the baby and put the baby back on CPAP. Next slide. Okay.
Dr. Ramesh,
yes.
Sorry to interrupt. I think another 4 or 5 minutes.
Okay, I'll try to do that. Okay. It is really very important that we make sure that the respiratory support that we are providing is adequate. And how do you judge that baby is comfortable, the saturations are normal, baby's color is good, and good urine output. Next slide. And next is that if you suspect that it could be sepsis, in that case, you need to provide first dose of antibiotics, and you can go through these slides that what are the situations when you should suspect that. Next slide. And the next issue is fluids and feeding. So if you have a baby who's more than 30 weeks, hemodynamically stable, not severe RDS, and abdomen is fine, in that case, you can start the baby on oral feeding there and then. There is no need for IV fluid. But if it is a small and sick baby, then initially you need IV fluid, and then you can start the baby on oral feeding at the earliest possible opportunity. Next slide. Now we come to the what could be the cause of respiratory distress, and I may have to skip a lot of slides, and you can go over it at leisure. So there are many causes, but if we talk about the common causes, then RDS, transient tachypnea, pneumonia, meconium aspiration syndrome, malformations like TEF and CDH are the common causes. But extrapulmonary causes can also cause respiratory distress. So you need to keep those conditions also in mind. Next slide. Okay, the approach is largely clinical. You go through the history and clinical examination. Investigations have only a limited role, and chest X-ray and sepsis screen alone would be enough. Next. You look at the history, you can go through the slides, and always clinical approach is most critical and would give answer to in majority of the situations. Next slide. You do the clinical examination, look at the gestation and degree of distress. Next slide. You in the clinical examination, you can find umbilical sepsis, pustules, means could be pneumonia. Next slide. Or you could have, next please. You can have meconium staining of the cord and nails, signifying that this is meconium aspiration syndrome. Next. Or you can look at the shape of the chest. If this chest is deflated and likely to be RDS, if you have hyperinflated chest, then this could be meconium aspiration syndrome. Next. You can keep changing maybe, yeah. So you can see scaphoid abdomen of CDH or mucousy baby. Yeah, my time is also beeping. Excessive drooling, that could be there. Next slide, please. In the tracheoesophageal fistula. X-ray, there are different pictures. Again, you can go through the slides. This is RDS X-ray. Next slide, please. You can see different degree of severity. This is TTNB, and you can see horizontal fissure out there. The findings are enlisted. Kindly go through it. Next slide. You have meconium aspiration syndrome. The most important thing is heterogeneous disease. You find whiteness at some place and blackness at other places, likely to be meconium aspiration syndrome. Next slide. Or CDH. Next slide. Or you could have next further. So this is TF X-ray. You can find the coiling of the tube happening. Next slide. This is most common variety of tracheoesophageal fistula. Next slide. This is a pneumothorax. You can see air and then the collapsed lung. Next slide, please. You may require sepsis screen where the probability of sepsis is high. There you take blood culture and run the sepsis screen. There is an error here. This is not absolute neutrophil count, but total leukocyte count. Kindly go through your FBNC manual. It is given in detail over there. Next slide. Right. So this is how you can differentiate between different common conditions: RDS, TTNB, pneumonia, meconium aspiration syndrome. Kindly read it in this slide. Okay, next slide. So now we are coming to the specific treatment. We talked about surfactant treatment in RDS. You need antibiotics in pneumonia. Meconium aspiration is basically all supportive care, and you might need ICD for pneumothorax, and you need surgical consult for a suspected cardiac disorder. Next slide. Okay, make sure that the supportive care is very, very important, like the temperature, comfortable breathing, feeding, prevention of infection, involving mother and the family. Next slide, please. It's very, very critical in the management of the babies, right? So it's not we only who are managing the babies, but it's the family which has got substantial role to play. You need to monitor these babies, and the message that I wish to give is, next slide, please, that you need to monitor these babies using a proper chart. And I'm quite sure there is a chart, and you can decide the frequency, whether the baby needs to be monitored every 2 hours or 4 hours or 6 hours. It is also important that you prevent harms. We do a lot of harms. So therefore, prevent harms, be aware of that. You can see that CPAP injury because of improper use of CPAP cannula. Next slide. So aware of the harms that can happen and promote healing environment. Very, very critical, and it's good, and we are proud of that, that we newborn people looking after the newborns are far more aware of these issues, and we practice these issues far more often than any other specialty. But I think we need to continue. Next slide, please. Need to continue to do that. So coming to the key messages, distress is a common problem, and most neonates can be managed with modest resources at your SNCUs itself. Manage them in a proper manner, TABC, right? Don't go like what is the cause, and it does not matter what is the cause. You'll come to that point at some point, right? Babies would need different levels of respiratory support. Look at the gestation and severity, and then majority of the babies, and then that's the great thing about the distress and in general any newborn disorder, that majority of them recover very well without any sequelae, and you have a baby who might look after us when we turn old. right? And promote healing and humane environment. Be aware of not causing any harm to the baby. And thank you very much for this opportunity. And it was lovely to talk to you. There is a small quiz that you can, Kapil, just go back. People can read and then maybe write an answer in the chat box. Thank you very much, Sushma. Over to you.
Thank you, Dr. Ramesh. That was indeed very lucid and presented very well. And I did see that you tried to simplify things as much as possible, although surfactant and high flow nasal cannula as well as CPAP were talked about. So thank you so much for that. At times, I feel that we need more time for things to be explained even more, in an elaborate manner. But there are time constraints. So I'm sure many of our attendees are able to understand a lot of it. There were a few questions in the chat box. The most important or the most pressing one for me to address here is oxygen therapy. Many of them have felt that if the baby is saturating at 92% or 93%, it is not good, and we must give some oxygen. For an asphyxiated baby, we should give some oxygen. So let me make it very clear, and all panelists are with me on that any baby who has respiratory distress, please apply the pulse ox probe, see what the pulse oximeter is reading. And if it is maintained between 91 to 95%, you do not need to start oxygen. All you need to do is keep monitoring. If the baby does desaturate, you have your oxygen right at hand, because do not think that oxygen is something which is a panacea, which is something very good. It does harm the baby, even term babies, not just preterm. So do not give it unless required. If the baby is saturating between 91 to 95, fair enough. Just keep monitoring the baby. Dr. Ramesh also touched upon a very important aspect: clothe the baby. Many people, many amongst us, feel that if the baby has respiratory distress, I have to monitor the baby, I have to count his respiratory rate, so I have to keep him completely naked and he's under the warmer. Please do not do this. Even if you have to count the respiratory rate, you are probably going to do it 1 minute in 1 hour, even if you do it every hourly. Rest 59 minutes, the baby can remain covered, right? So please keep the baby covered. You can still monitor him while he's covered with a sheet or wearing a jhabla, and you can see the chest movement to be able to count the respiratory rate. ET suction is being talked about repeatedly in the chat box. I would just like to say that based on evidence, it is not recommended. So as of now, the current evidence is that it is not recommended. Suction pressure, somebody has asked, I think it's been answered. 80 to 100 millimeters mercury is the maximum. So you need to set it to 100 and not let it go beyond that when you are suctioning a baby. High flow nasal cannula, Dr. Ramesh, unfortunately, right now it is not in the equipment list. So I'm not sure if any of them are exposed to that. But as you rightly said, it is something which is very simple to use. Babies love it, nurses love it. And CPAP does have propensity for nasal injury, but that is not there or minimally there with high flow nasal cannula if we do not snugly fit the cannula. So you very rightly address that. And as we go on talking more about what equipment. Have I been muted by the host?
No, you are audible.
You are audible, madam.
All right. So CPAP is being provided to some of the SNCUs which are performing to a certain level, and Headbox has been there with you, but I would only say that when you have to choose between them, nasal cannula is a low flow device. You just need half to 2 liters of oxygen. With a Headbox, you will certainly require something like 2 to 4 liters or 3 to 5 liters. So it will be judicious on that, and as well as the baby may be comfortable. However, if your baby is a term baby, not comfortable with the nasal cannula, you can always use the Headbox as required. And I have seen questions related to baby not being taken in the higher center. What do I do? What do I do? I would just like to respond, Doxa. There is PMJY, there is JSSK. You can spend on the baby and not charge the family for any out of pocket expense. So there are ways and means being provided by our government to be able to take care of such babies. So I think we will now move on because time is really running fast, and I can see Dr. Aarti, who has joined us. So the next talk is on a very important aspect. It may not be an emergency per se every time, but this is something very important, and most babies are jaundiced during the first week. She will let us know which babies really require therapy, which babies are the ones who we can just monitor and not do anything more for them. It does have a lot of neurocognitive sequelae later on if it is not managed appropriately. So I will request Dr. Aarti Maria, who is the head of neonatology at RML Hospital and Atal Bihari Vajpayee Institute of Medical Sciences, to enlighten us on the topic of neonatal jaundice. Dr. Maria has done a lot of path-breaking work, and we will be listening to her thoughts on neonatal jaundice. Dr. Maria, please.
Thank you very much, Dr. Sushma. And I first of all want to acknowledge my gratitude to Government of India Ministry of Health, Dr. Manohar Agnani, who's the Additional Secretary RCH, and Dr. Sumita Ghosh, who's the Additional Child Commissioner Health, Additional Commissioner Child Health, and Dr. Kapil, I think, and the whole team who have left no stone unturned to actually make this a fantastic, success. And I think it's a fantastic initiative by the Government of India Ministry of Health to get everybody together and in challenging times like present. So I think it's a huge opportunity for us all to learn and also see the ground challenges what everybody is facing. So good afternoon, namaskar to everybody, and I would talk on neonatal jaundice. I have tried to make my presentation simple, and I would start with just making you understand what is neonatal jaundice, how is it, why should neonates have so much of jaundice, how so commonly do you see jaundice, why should it be there? This is because they have an increased red cell mass, the RBC lifespan is shorter, and there is the destruction of or the cycling of the RBCs which occurs involves creation of bilirubin as a pigment, which is the one which is responsible for showing jaundice. And this, because the liver functions are not so mature to be able to handle the bilirubin, the unconjugated fraction actually appears and shows up as jaundice in the newborn. Moreover, if we don't feed the babies, they are fasting, or there is delayed enteral feeding, there is also stasis, and then that leads to increased enterohepatic circulation, and thus the bilirubin levels can actually rise. So I think it's important to understand, because newborns parents, they often ask us, "Mere bachche ko jaundice hai, my baby has jaundice." They get really anxious. But we need to tell them this jaundice in an adult is completely different from a baby having a jaundice or neonatal jaundice. So we must allay their anxiety and tell them this is not because of liver disease. It's only a functional immaturity to be able to handle the RBC load. This is the first important message I want to give. Now, next, please. So jaundice is defined as apparent jaundice in a newborn appears at serum bilirubin levels of more than 5 mg/cent. Why is it important? I told you it's a common and a very serious cause of parental concern. They think baby is just born and baby has jaundice, and all they know about jaundice is that it is a serious liver disease. So we need to tell them and reassure them. As many as 60% of term newborns and even more in preterms have jaundice in the neonatal period. And why it's important, as Dr. Sushma said, it is associated with possible severe complications which include deafness and very serious neurodevelopmental problems if not attended and managed promptly. Next, please. So I want all of us to understand that there is a distinct physiological and a pathological jaundice. If we see the graph on the left, it shows us physiological jaundice and differently in term and preterm babies. As you can see, the jaundice which is physiological does not appear on the first day, On the x-axis, you can see the age in days, and on the y-axis, you see the bilirubin levels. So you are seeing clearly the jaundice appears after the 24 hours, any time between second or third day of life. It does not cross 15 milligram percent. And in term baby, it is almost done with by the 12, 13 or second week. In the preterm, because of further immaturity, it can take up to 3 weeks to resolve. This is how we need to differentiate physiological and pathological jaundice is one which could appear within 24 hours. It is rapidly rising to more than 5 milligram percent levels per day, may persist beyond 3 weeks. Serum bilirubin is above 17 milligram percent. Palms and soles can be yellow, which means the level is distinctly higher than that. And if any baby with jaundice appears with signs of acute bilirubin encephalopathy, then it has to be taken as an emergency. Or there is evidence of cholestasis, which means the baby is also passing high colored urine and there is an associated liver disease. That points towards the jaundice being pathological and not physiological. Next, please. In 1990s, there were a lot of case reports that reported full-term healthy breastfed babies were reported to have very high bilirubin levels and even developed kernicterus, which is the sequelae of the chronic bilirubin encephalopathy. Next, please. So there came the research, and this normograms for risk prediction were developed. So I'll just try to spend 2 minutes on this because it's important. So when we are wanting to discharge a baby, how do we know that this baby will not come back with a high bilirubin level? Because babies can present much later with much higher and risky or dangerous levels of bilirubin. So it's a good idea to follow these, use these charts, which are the hour specific bilirubin charts. We must have them pasted in the SNCU. So if you see along the x-axis, the age in hours and the total serum bilirubin, mind you, it's total, not the differential or the unconjugated fraction. So the total bilirubin on the y-axis. So if you see any baby you want to discharge, supposing there is a bed shortage and you want to discharge a baby at 24 hours, and you see the baby, not yet, Kapil, please move back. So at 24 hours, supposing the baby does, can you remove this slide? Next, previous one, please. Previous one, Kapil. Yeah. So if the baby is at 24 hours of age and he has no visible jaundice, if you see plotted on the 24 hours and you see no jaundice means less than 5. So this baby clearly falls in the low risk zone. And low risk zone means important is if a baby has no jaundice before 24 hours or by 24 hours, he is likely not to have a bilirubin which will go above 95th centile. Accordingly, we can also predict if we want to, like if a baby has at 48 hours, baby has a bilirubin which is about, let's say 15. Can you see where the 15 is meeting? I don't have a, oh, I can manage. So can you see the cursor at 48 hours, the baby has a bilirubin of 15, which is here. So this bilirubin level is clearly falling in the high risk zone. So this baby has about 40% chance that he will go into hyperbilirubinemia with a level above 95th centile. Next, please. So the previous one. Yeah. So if we see this, let's understand the summary of this hour specific bilirubin charts. So if the total serum bilirubin, according to this chart, is falling in the high risk zone, there is a 40%, almost 40% chance that the baby will have bilirubins above 95%. The babies who are, if the babies are in the low range, they are almost, the negative predictive value is 0, which means they are almost likely not to have any chances of hyperbilirubinemia. Next, please. So this kind of risk categorization helps in predicting the bilirubins that the baby can possibly have. So it gives us a sense of preparedness. So those falling in the high risk zones are clearly pathological, and those in the low risk possibly physiological. Next, please. So at discharge, we must assess for risk factors for severe hyperbilirubinemia. We must know that the major risk factors are gestation, because all these studies have been done for babies more than 35 weeks of gestation. So for a major risk factors, gestation is 35-36 weeks. Pre-discharge bilirubin in high risk zone in the last graph that I showed you. Jaundice appearing in first 24 hours. Setting of blood group incompatibility with a positive DCT. Kapil hematoma or bruising, and exclusive breastfeeding, especially with feeding problems. And the minimal risk factors are gestation more than 41 weeks, bilirubin pre-discharge is in the low risk zone, baby is top fed, black race, and the discharge after 72 hours. So there needs to be, the message important is that close follow-up needs to be done for babies according to the individual risk categories that they belong to. Next, please. So what about the type of feeding in jaundice? It has been seen, although we know that breastfeeding is the best, and the message I still want to reiterate and reinforce, breastfeeding is the best and needs to be encouraged for all. The point is that observations have been done and seen that 2/3 of babies who are breastfed may have clinical jaundice up to 2 to 3 weeks, and bilirubin level of more than 12% was seen in 12% of breastfed. So clearly, the formula-fed babies have a lesser incidence of hyperbilirubinemia compared to those who are breastfed. Nevertheless, the point is that not that breastfeeding is not to be done. Point we are making is breastfeeding should be done with all vigor and rigor, but it should be supported, educated. Make sure the baby is feeding, and initiation and establishment of breastfeeding occurs, and that will happen through early breastfeeding, early best breastfeeding practices like early initiation, skin to skin, proper 8 to 12 times being fed, and avoid supplementation and watch out for the urine output. Next, please. So what is the approach to a jaundice neonate? And as I just mentioned, these criteria need to be looked at. Next, please. So for clinical assessment of jaundice, we examine the skin and skin or eyes in natural light. No yellow background that can really affect your assessment. Absence of jaundice excludes jaundice. That is not doubtful, provided no phototherapy has been given. In initial 3 days, all babies need to be seen almost every 12 hourly, more frequently if there are risk factors. And serum bilirubin peaks around 72 hours in term babies and even later in preterms. For follow-up, the parent must be counseled for needs to follow up. Very important. All babies should be seen at least 48 to 72 hours if they are no risk or low risk babies after discharge. The babies at higher risk should definitely be identified with a star on the discharge slip and with phone numbers, and must be contacted if they don't show up, and they must be kept under close follow-up for progression of jaundice. And our specific bilirubin charts really help us. Next, please. Yeah, so you can see you're all familiar with assessment of jaundice. In the upper picture, you see there is no jaundice. In the lower one, it's a deep jaundice. Next, please. So we are all familiar with the cephalocaudal from top to bottom progress of jaundice. It doesn't always follow 100% that the intensity sometimes is very deep, but the jaundice may be in the upper part or up to the legs, but bilirubin levels may be much more. But this is a gross or a crude, the rule of cephalocaudal is very true. So intensity, while at the same time, I want to also say that intensity of depth of jaundice is also important. All I want to summarize from here is soles and palms, if they are stained, the bilirubin is clearly more than 15 milligram %. And if it's deeply stained, you must treat it as an emergency, start immediate phototherapy, and maybe plan for an exchange. Next, please. So a baby with jaundice who has physiological jaundice, please assure parents, ensure appropriate follow-up. No need to, as we are talking of do no harm. So no need to check serum bilirubins routinely. If it is pathological, do total bilirubin, ABO and RH blood grouping for baby mother, DCT if ABO or RH setting is there, mother RH negative, baby RH positive, mother O positive or O negative, and baby is A or B or AB. PCV, hematocrit, reticulocyte count, peripheral smear for hemolysis. Although I must say a peripheral smear examination is not very sensitive for picking up hemolysis. Reticulocyte count helps. And hemolysis means there may be lesser hematocrit, and you must do G6PD if it is coming from that area, the patient belongs to that area, or if bilirubin is rising or the hemoglobin is falling. Next, please. Now, we are all familiar. I think you will all be having a transcutaneous bilirubinometer, as you can see in the picture. And this really has brought down the need of sampling. It helps the visual assessment as well as the bilirubin assessment by blood, because you can actually do away with that. And next, please. The limitations, however, is that in less than 35 weeks, the studies have not very much established the reliability, and especially so in the first 24 hours of age. It is also not very useful in babies under phototherapy, and values of more than 12 to 14 milligram should be confirmed by bilirubin, by serum bilirubin testing, because however, the correlation at lower levels is reasonably good. Next, please. Next, please. So how the other method, so we talked of visual assessment, we talked of transcutaneous bilirubinometry. Now we talk of serum bilirubin measurements. Next, please. So serum bilirubin measurements can be done with this point of care bilirubinometer, which uses capillary blood estimation using spectrophotometry, and the lab estimations using the Vandenberg reaction and the chemical. So lab takes time. That is why this point of care bilirubinometry must be there. It's a very, very essential equipment at all SNCUs, and you must actually use it and not depend on lab values, because lab values are actually notorious for giving you a lot of lab errors to a huge tune. So don't be confused. Use your clinical assessment. Use your capillary bedside bilirubinometry. Next, please. Next. So frequent bilirubin assessments, measurements depends on the underlying cause. So clearly, if there is a hemolytic or a severity of jaundice is a lot, or there are host factors of risk factors, then you need to do it frequently. Frequently could also mean 6 to 8 hourly in clearly high risk settings. In non-hemolytic, where the TSB levels are in term babies below 20 to 25, it can be performed 12 to 24 hours. And a baby with RH, as I said, can be requiring 6 to 8 hours in the first 48 hours. Next, please. So now, how do you manage, how do you decide which baby gets phototherapy, which baby doesn't, which baby requires exchange? For this, the AAP, American Academy of Pediatric 2004 guidelines still stand the truth of time. And this applies for babies who are more than 35 weeks of gestation, or let's say more than 2.2 kilos or 2.2 kilos. Next slide, please. So we all know that total value of bilirubin is taken. I'm repeating. Risk factors, we are all familiar, that include hemolytic anemia or isoimmune hemolytic disease, G6PD deficiency, asphyxia, hypothermia, sepsis, acidosis, hypoalbuminemia. The AAP normograms for phototherapy and exchange, which you all are familiar, has 3 risk categories depending on the risk factors. And to top it all, or the final bottom line is, if you for the first time are seeing a baby who has signs which could be possibly due to bilirubin brain damage, a bilirubin induced neurological dysfunction, BIND, like hypertonia, retrocolis, convulsion, fever, then you have to immediately plan and start working for an immediate exchange, regardless of the level. You don't have to wait for the bilirubin levels. Next, please. So, as I said, supposing the total bilirubin is 15 and direct is 2.5, the bilirubin taken into account will be 15 for these charts. Next, please. So we are, next, please. So we have two groups of babies who are term more than or near term more than 35 weeks, babies who are preterm less than 35 weeks. So obviously, next please. The charts that we are familiar, they are the ones which are for babies more than 35 weeks, and these are the phototherapy charts. The solid line indicates the babies at higher risk, and the dotted top line is the one which is for babies with no risk or lower risk. So can you understand now why the solid line is having a lower level of threshold for lower bilirubin for starting phototherapy? Because they have risk factor. A baby who has no risk factor, for the same age, that baby will require phototherapy at a higher level of bilirubin as compared to a baby who is at the same age but he has risk factor. So you will start, for instance, at 24 hours for a baby with risk factor, you will start phototherapy at bilirubin level of somewhere like 7 or 8, whereas for a baby with no risk factor, you will start it at 12. Next, please. Similarly, you have similar graphs for exchange transfusion cutoff. So these and the hour specific are extremely helpful bedside tools for helping us guide management of bilirubin management in babies. Next, please.
Dr. Aarti,
Yeah.
we have 5 more minutes.
Well, okay, I'll respect that. Yeah. So similarly, there are guidelines for preterm babies. Next, please. But however, there is a rule which is listed here. Okay. So the therapeutic options are, we're all familiar with phototherapy, supportive care, exchange, and drugs. Quickly. Next. Phototherapy, next, please. Next, please. Phototherapy remains the mainstay of managing. It actually converts, next please, it converts the insoluble bilirubin into soluble isomers, which can be excreted in the urine. Next, please. And the bilirubin wavelength, which is the key wavelength, is 490 to 520 nanometers. Next, please. And the type of phototherapy lights, you're all familiar, is the CFL lights, the blue compact fluorescent lamps, high intensity LED lights, which have a long life of lasting, and much more irradiance, and fiber optic units, which next please. Fiber optic unit, as you can see in the extreme left corner, which can be used for giving a undersurface, and the CFL lights and the LED lights. Next, please. So administering, we are, I think, very familiar. However, just quickly, remove clothes except diaper. Temperature should be monitored. Cover eyes, cover the male genitalia, and distance should be 30 to 45. If you're using lesser, then you have to monitor temperature. Next, please. So care under phototherapy, frequent feeding. You can turn the baby every after feed, temperature monitoring, urine frequency, and monitor bilirubin level. Next, please. So efficacy can be dependent on these factors, and of course, the level of the jaundice and the hemolysis versus non-hemolytic. Next, please. So to maximize the efficacy of phototherapy, the irradiance of phototherapy, I think the most important message here is, please don't think that the phototherapy lights you've been using will last you for ages, forever. They have to be measured for their irradiance, and it should be above 30 microwatt level. And you have a flux meter with these. Expose maximal surface area of the baby. Ensure good hydration. Baby is passing 6 to 8 urine per day. And make sure light falls on the baby perpendicularly and minimize interruptions. However, feeding definitely can continue. Next, please. So LED phototherapies have reduced the need of exchange, and people have used, next please, reflective materials like this white surface, which has shown that it probably increases the irradiance by reflective method. Next, please. So monitoring, I've already mentioned. When do you stop phototherapy? Measure TSB depending on what is the underlying cause or how rapidly it was rising every 12 to 24 hours. Discontinue if two TSB values are below age-specific cutoffs, because once on phototherapy, TCB no longer, transcutaneous doesn't help us much, nor even the clinical management, clinical assessment, sorry. So measure TSB values after the stopping to look for rebound. However, rebound is, I think, overhyped because usually it will never happen more than 1 to 2 milligram percent. Next, please. So side effects, to mention these, but to say messages, there are none significant. Next, please. So the next modality, role of sunlight, nil. It could be possibly be harmful. We do want to do no harm. So no role of sunlight, clearly. No, next. Exchange transfusion. I think if our management and assessment of babies is good, our need of exchanges should come down absolutely. If a baby you are first time seeing and his bilirubin is 18, that reflects poor quality of care. Because if you are first time detecting a level of bilirubin of 18, that means you have missed because jaundice never starts with 18. It must have started with 5, 7, 8, 10. So we must pick it up early, start phototherapy if it is indicated, and the need of exchanges should be minimized. Next, please. So exchange transfusion, these are the indications, these are theoretical, so I'll leave this. I'm talking about practical things. So next, please. And yes, next, please. This is the simple way to say what is exchange. Double volume means you use double the volume of the baby's blood volume. And what it's a very simple thing, principally, the donor blood goes in and simultaneously the pull push technique. So you are removing and you are pushing in, so pushing, pulling, so these kind of cycles go on till the double volume of blood has been exchanged. Next, please. Choice of blood, this you have to have this bedside to know the right, it's important, but it's listed here. Next, please. Next, please. Next, please. Yeah, there are other things just to mention. IVIG, only IV immunoglobulin, limited role in ABO, but definite role in RH isoimmunization. Phenobarb, albumin, steroids, no role. Next, please. Effects of bilirubin, this is what is the dreaded complication. We don't want this to be happening. This is again a very, very important quality of care indicator. If a thing as benign as neonatal jaundice lands up with babies with bilirubin toxicity, I think it brings us to shame. And this is what we need to avoid. The two terms which are used are acute and chronic bilirubin encephalopathy. The chronic part is the sequelae, which is called kernicterus. And it is due to toxicity of bilirubin 2 because the unconjugated fraction, that is another way how the adult type of jaundice differs from the neonatal jaundice, because the unconjugated fraction can cross to the brain. The conjugated does not, which happens in adults. So brain injury due to bilirubin doesn't occur in adults, but it can happen in newborns only. Signs of, please remember and recognize, this is equally important to recognize signs of acute bilirubin encephalopathy, which is bilirubin induced neurological dysfunction. I will read them out because it's extremely important. Watch out if a baby is lethargic and has a deep jaundice, do not ignore it. Lethargy, decreased feeding, hypotonia, stupor, irritability, hypertonia, these are late signs. If you have found this baby in this stage, anybody can pick up. You have to pick it up early, and if in doubt, plan for an exchange. Advanced signs are like these. As you can see, these are the early signs relatively, and this is an advanced stage of sequelae. Next, please. So this is advanced stage, and the long-term sequelae, athetoid cerebral palsy, auditory dysfunction, dental dysplasia. This is like really we should be ashamed if the baby has come back to us. So this is next, please. So the message is kernicterus is absolutely preventable. I meant the word is absolutely, not potentially. 100% preventable. And why does it occur? If we have early discharged the baby early without follow-up within 48 hours. If we have failed to check the bilirubin level particularly if the onset was in first 24 hours. If we have failed to note the risk factors, if we have not visually assessed or underestimated the severity, if we have delayed in testing the jaundice newborns or treating the elevated levels, if we have a lack of concern for presence of jaundice or even lack of concern for parental concern, this is how kernicterus happens. Next, please. Key message, the last one. We must emphasize on primary prevention and risk assessment. Early prediction of severe hyperbilirubinemia is crucial in preventing kernicterus, which is 100% preventable in babies who are discharged early. And finally, again, we have reached an era, we talk of advances in neonatal medicine, we are talking of HFO, ECMO, but I think first things first, do no harm. We should never, let's all pledge we will never see a baby of kernicterus, because a baby who is taken through or gone through our hands of care should never develop kernicterus. Thank you very much.
Thank you, Dr. Aarti. I could very clearly see that you were trying to tell us as much as you can about neonatal jaundice, which is such a good thing. But, time is something at a premium, and we have other things that need to be taken up after this. So thank you very much for your presentation. And there were questions in the chat box related to, is early onset jaundice same as physiological jaundice? What is pathological jaundice? Does it always occur always within 24 hours and so on? So you would have all seen the graph shown by Dr. Aarti, which was like this. So anything that occurs before, which is before 24 hours, anything which occurs more than the levels that are there for age specific is pathological. Anything that occurs beyond the physiological. So if physiological is beneath this kind of a mountain, then anything which is before, above, and after this curve is pathological. So you can't say 14 is pathological or 12 requires phototherapy. It has to be taken in the context of baby's age when the sample was taken, not when you get the report. So there is confusion about physiological and pathological jaundice, which is very simple to understand. It cannot be at a point you can't say this is physiological, this is pathological. It can be only said in retrospect after you've looked after that baby. So that baby needs to be monitored for whether the bilirubin is rising clinically and whether you need to sample that. Not all babies with jaundice, as she rightly mentioned, need to be sampled to see what the level of bilirubin is. She has also very rightly told us that the babies must be fed. The sooner the gut gets cleared of meconium, the sooner the baby's bilirubin is going to come down. AAP charts also, she made an attempt to explain them as to what is low risk, what is high risk, and what is medium risk. So it is in context of the bilirubin level on y-axis and the baby's age on x-axis when you have taken the sample. So you're going to analyze that. Does it fall on the graph, on the curve, or it falls above the curve? That is a baby who will require phototherapy. So I think the alert signs for the parents that need to be told them is if the baby has high colored urine, if the baby is passing clay colored stool, or if the baby has palms and soles which are yellow, that is certainly alarming and the baby must come to a facility. So thank you very much, Dr. Aarti. And if there are any more questions in the chat box, we will look at them. And I'm so thankful to Dr. Agnani, Dr. Ghosh, and Kapil for giving us this opportunity to interact with almost 2,000 of our frontline warriors. Thank you very much. The three topics that were presented in a very lucid manner. And I only have one promise to make to all those 2,000 of you who are there, that we will come back with more topics, with more clarity. Maybe we will not pack in 3 topics in a webinar. We will just have 2 of them so that there is more time for the expert to interact with you. And I must tell you, all the effort that is going in to reduce the neonatal mortality, to improve the neonatal outcomes, is your effort at the ground level. It's not our effort, it is your effort. You are the ones who are making that difference. So we all salute you for the work that you are doing at the place wherever you are working, and we are always there to help support. The ministry is there to help and support with infrastructure, with equipment, with manpower, with whatever that is required. So with that, I will end the technical session here. Thank you very much, Dr. Neeraj, Dr. Ramesh, and Dr. Aarti for your deliberations. Over to Dr. Kapil for the subsequent part of this webinar. Thank you so much.
Thank you, madam, for conducting all the technical sessions and moderating all the sections. It was really a very good sessions. Now we will move to the another session, which we can say this is a peer learning kind of session. So in this regard, as the time is very short, I am cut shorting my voices, and I would like to request from Himachal Pradesh, Dr. Hiten Banial, to share his state experiences.
So good evening, everyone. First of all, I'll just like to express my sincere gratitude to our AS Sir, Dr. Manohar Agrani, and Madam Ghosh, Additional Commissioner, and especially our Dr. Kapil, who has given the state of this opportunity for talking about our experiences. So first of all, I will, as you all are well aware, that Himachal Pradesh has a very difficult terrain and a different topography. We have plain districts also, and we have a hilly terrain districts also, which are even hard to reach. And going in this through, I'll just share that when we are talking about as such whole, talking about the neonatal mortality rate, we are at right now at 13 as per the SRS reports. So we are working hard. So now state has gone into a holistic approach. As we can see that all the if we talk about the life cycle, all the talking about the mother, child, newborn, adolescent, they all are interlinked in between. And to strengthen that interlinkage and further to get a good outcome, definitely to reduce NMR, we first of all at the state level, state had taken an initiative of building up a health index based on these process indicators, because outcome it is very difficult to monitor. So these process indicators, if talking in this, we have taken holistically, we have 91 indicators on which we rank all the districts, and the review is done on quarterly basis. If talking specifically about child health and immunization, we have all the facility based indicators, like talking about vitamin K was administered against the institution deliveries, or whether how many institution deliveries are there and home deliveries are there in the districts. This with this holistic approach, like health and wellness centers, how is the performance, what are the functional process indicators, we just focused on the process indicators, which definitely will bring impact on our neonatal mortality rate. So with this, we had a very healthy competition between the districts also. At state level, it is reviewed on quarterly basis by our Secretary Health Sir, and at the district and block level, we had made that mandatory that all the reviews are done based on those indicators. So with this, we are trying to, as a holistic goal in the approach for this, reducing the neonatal mortality rate. Now, if definitely talking about the facility based and the community based approach in child health, as you all know, we have 16 SNCUs in our state and 49 NBSUs. So talking about the SNCUs, we have we have done a meticulous work in getting the KMC done, family participatory care. Then if like I can even show, we have, as per the SNCU portal data, since last year, there is a difference of around about 20 to 30% if talking about any SNCU, the admission rate. So the acceptability of institution delivery in our state, we are definitely focusing on that, because institution delivery will definitely all this after, if institution delivery is there, quite obvious, we'll ensure ANC visits also, and timely the vaccination is done of the mother, iron is provided to her, so that further if any kind of complications are there, they could be either avoided or they can be managed at the SNCUs and NBSU level. So if like in for example, I'll just quote an example of our at Medical College Tanda. there is an increase of around about 15% compared to the last few years data. There's an increase in the admission rate, and definitely at the SNCUs we are trying to ensure that there is management of quality, like internal assessments are done there time to time. If any there is a crunch of HR, if talking about the staff nurses and all, definitely that is rectified on priority basis. So with this, we have some more initiatives. I'll just share a field story shared by one of our pediatrician from aspirational district Chamba. There was this lady during amid of COVID times who delivered with a preterm weight of 700 grams. So it was a SNCU. They managed over there the child. The unfortunately mother was also in acute psychosis. She was referred to a very different health to a tertiary care unit. So it was very difficult for the doctors and the staff nurses over there to manage such a baby. And as you all know, we don't have any kind of milk bank also available in our state. So we in all the things we try to get expressed breast milk from another mother. So with that, which right now the baby has gained a weight of 1200 grams, and what the latest I got the news was, it has gone for right now ROP screening. So what I want to give the messages from this is that all our pediatricians, all our MOs and staff nurses, we have a strict objective that we will not substitute any kind for human milk. So we are totally I know how it's very difficult in aspiration district how they work. So we all have this objective that exclusive breastfeeding should be there, and there should be no substitute for our human milk. So
thank you, Dr. Hiten. Thank you, Dr. Hiten, for sharing your very good examples. One thing I can say is that our Madam Sumita Ghosh is always telling us in our department that whatsoever is monitored, which is improved. So we need to create a monitoring at our state level, at our national level, and at our district level. And you at Himachal Pradesh created a very good healthcare kind of index. And second good thing which I came to know from your end, that you are doing a holistic kind of approach. You are not only you are monitoring the child health related aspects, you are also monitoring at the same time maternal health kind of aspects and adolescent health also. So this is the good learnings from your end. Now in the next thing, I would like to request from Telangana, Dr. Hima Bindu. She is a child health nodal officer and professor of pediatrics from Nilofer Hospital also. So madam, please share your good experiences from Telangana. Madam Hima Bindu, please.
Yeah. Very good evening, Kapil. Thank you for inviting me. I thank the Government of India for organizing such a wonderful, I think a national level, so many SNCUs have come together. I also would like to send my greetings to my colleague friend, Dr. Sushma there. Hello, Dr. Sushma. And it was a pleasure to hear to all of you, Dr. Ramesh and Dr. Aarti. From Telangana, I think we are, due to our hard work of all our nurses and SNCUs, I think we are in the second in the whole country for delivering good newborn care. And all these things are happening just because of good leadership here, political will, and also we have gone into accreditation. A lot of our SNCUs are into quality, and indicators are being maintained, and many of our SNCUs have been accredited by NNF, and we are also now into a lot of QI projects, especially Nilofer Hospital, where I'm heading the department neonatology. We are sort of mentoring all the SNCUs for QI, and we have under us all the SNCUs and also the medical colleges and some of the private sector facilities also, where we had a 2-day whole workshop on the QI methodology, and since then we have taken up many QI projects. For those, I think बाकी जो SNCUs जो nurses हैं जो हिंदी में जानना चाहते हैं, तो उनको हम बोल रहे हैं कि हम सब गवर्नमेंट में कॉमन प्रॉब्लम्स हम मतलब सबको होता है कि वी हैव लॉट ऑफ लोड, जो काम बहुत होता है, बट वी डोंट हैव दैट टाइप ऑफ ह्यूमन रिसोर्स. जैसे हमारे यहाँ भी जो एसएनसीयू है, इट इज एक्चुअली कैटरिंग टू लॉट ऑफ इनबॉर्न. वहाँ पे जो 20 बेडेड के बदले में वी आर रियली कैटरिंग टू 3 times मोर. हमें 60-70 इनबॉर्न्स एवरी टाइम होते हैं, और आउटबॉर्न्स इट गोज अबव 150 to 170. तो इतना आई थिंक वो सबसे लार्जेस्ट लोड बोला जाता है, आई थिंक ऑल ओवर द कंट्री और मे बी द ग्लोब. वी हैव बीन at any moment we see around 300 newborns in our department on bed, and therefore I think we have a very huge load, and we always have this human resource crunch. The nurses are never enough, and therefore we have been actually allowing lot of family members to come in since long time to take care of the babies, which we now call family centric care. But with this, of course, structured guidelines have been just recently come in, but we have been doing since long. So since though we have a lot of quantity to take care, so we wanted to be a role model to start of quality. So now the QI quality improvement जो methodology है, इसका हमने workshop करके सब nurses, सब doctors को involve किया, and ये I think briefly मतलब summary में बोलने के लिए ये है कि quality is जो हाई फाई चीज ही नहीं है. वी कैन डू विद इन स्मॉल थिंग्स. हमारे जो सर्कमस्टांसेस हैं, हमारे जो कंडीशंस है, उसी में कुछ हम इम्प्रूव कर सकते हैं. तो इसमें लाइक जो प्रोसेसेस इम्प्रूव करने के लिए हम लोग डेफिनेटली सब कुछ एट एवरी कैडर हम लोग कुछ कोशिश करने से जरूर हम कर सकते हैं. ये हमने बताया है. हमने 4 वर्कशॉप 4 QI प्रोजेक्ट्स वी हैव डन. वन इज बाय जस्ट स्मॉल थिंग लाइक इम्प्रूविंग आवर हैंड वॉश, परसेंटेज ऑफ हैंड वॉश. इसको हमने BMJ इसमें भी पब्लिश हुआ है जर्नल में. एंड देन ये इंक्रीजिंग दी KMC, duration of KMC. We know it's challenging. We all know कि breastfeeding important है, KMC important है, but actually if you see in the ground, कभी कभी को challenges face करते हैं, और उस वजह से हम लोग पूरा जितना हम करना चाहिए उतना नहीं करते हैं. तो we have to make some changes हमारे जो methodology में है, और हम इस चीज के लिए we are given the full team leadership to our nurses जो वहाँ के जो फैसिलिटी में है. सो दे आर द टीम लीड्स. जो नर्स है या फिर इवन द आयमा दायमा या सपोर्टिंग स्टाफ, उसको टीम लीडर बना के उनके साथ डिस्कशन करके ना वी ऑल फॉर्म अ टीम. तो प्रोसेसेस में चेंज ले आते हैं कि ऑटो टेस्ट करते हैं कि ये चेंज को टेस्ट करके देखते हैं कि ये इसको PDSA साइकिल्स बोलते हैं. तो वी डू दैट एंड वी हैव टेस्टेड, एंड देन एवरी फैसिलिटी कैन डू. इट्स नॉट दैट व्हाट वी डू सब कुछ वो बाकी सेंटर्स वो मे नॉट अप्लाई इन अदर सेंटर्स. So we all have to start, this mindset has to change कि हम लोग कि कुछ भी नहीं कर सकते हैं, ये इक्विपमेंट नहीं है, वो नहीं है. No, all that need not, quality के लिए we can start off with what we have. So I request all the SNCUs all over to kindly think over and go into a QI methodology to change some processes which is doable, and take up small tasks, and we can really create a big change. Like one success story what we have in Telangana is initiation of breastfeeding, which we call Mission Shigra. So what we did was we tried to utilize the presence of a birth companion. The birth companion is now mandatory under Lakshya. So instead of they standing there just like that, we actually trained them, and we have also empowered them to start initiation of breastfeeding. And we have put one stamp, like the sister only shifts the baby and the mother pair after the baby is initiated on the breast in the labor room itself, and a stamp is put on the case sheet saying that breastfeeding initiated. So whenever anybody goes for the rounds in the postnatal or anywhere, when they see this round stamp on the first page of the case sheet, so then we all know it is very much visible that yes, it is done. So now the other mother asks, why this stamp is not there in my case sheet? So that demand generation started, and everybody is so, in spite of this was in March, we got from 20% we almost went up to 82.5% early initiation rates. And but due to the COVID and all, we just came down. But in spite of that, whatever 6 months we had doubts about whether to breastfeed, not to breastfeed. So many things were there in the mind of the mothers. Still, our rates were not dropped, and it was around, we dropped a little bit to 72%, but still it is sustaining. So that is a big success story for our Nilofa Hospital and state of Telangana, and such many such QI projects we are doing all over the state of Telangana. So we have that we are the referral, and we keep on meeting on Zoom every 15 days. We have meetings with other SNCUs, and they share their success stories. Some of them are doing on hypothermia, some of them are doing on KMC, some of them are doing on antibiotic to bringing down the antibiotic usage. So we know that story of Kangaru Mother Care, Yadaya's unit in district Nalgonda, which is very popular at the district level. He could do so much. Success stories coming up from our district, from Telangana and Nalgonda. So these are few things, and we have now doing a lot of QI projects. The whole state is into QI. We are also doing referral guidelines have been made, and we want that our any essentials referring to us, we are the tertiary care, so they have to do in a very organized way, not just refer, and then we refer back to them. We also, some good practices, what I want to share is, now we are following up all the babies after discharge in a very organized way. If they do not come, we are attaching them to the Anganwadis and Ashas, which are supposed to be done, but so far it was not, that was a weak point. So we strengthened that part through the care companion program. So we also have a care companion now identified with the babies in our SNCUs. So a family member is identified, usually it is a mother or any father, anybody. So this care companion is now taught about the newborn care practices while they are with us in the unit, and then after discharge we follow them up. So these are some new initiatives which we have taken up: care companion program, the QI projects, and also the referral guidelines, and of course accreditation and quality. So these are few things which I would like to share from the state of Telangana. Thank you, Dr. Kapil, and it's my pleasure. If I think I've just given 2-3 minutes, I hope I could share some of the thoughts of Telangana state. Thank you.
Thank you, Dr. Hema Bindu from Government of India side. I can see that, nice to hear from you that all the Government of India's key programs like FCC, quality improvement, Lakshya program, birth companion, and everything you are following in your states, and which is giving you the good results also. One more thing I can say that I closely hear from your end every time that you are giving credits to your team also. It is showing your leadership quality also, that you are giving credits to your team. So now in the next session, I would like to move to the next session. And as additional secretary sir said that yesterday we launched a few packages, which is NBSU and NSSK packages. I would like to request my team members, Dr. Dipti, she is a drafting team member also for all these things. So I would like to ask her for few highlights for these two guidelines, that what technical changes we have done and we have proposed in these two guidelines. So please, Dr. Dipti, please tell us.
Thank you. Good afternoon, everyone. Thank you, Kapil, for this opportunity. So let me say that the Ministry of Health is finally, endorsed the two training packages, which has been in the making for a long time. And I think it will give a big fillip to our newborn care program. And all that work that is now being, it was launched by the our Honorable Health Minister yesterday. And it is effort and lot of work put in by a lot of newborn experts from the country. Lot of institutions have come together to develop them. So it is a collective effort of the ministry and all the experts and the partners in the country. So I would just like to say that amongst the two packages, the NSSK package, of course, as you all know, deals with the issue of essential newborn care and resuscitation. So you can be assured that in this package, all the important topics that we deal with in the essential care of newborns have now been included and updated. And in terms of methodology, I think there has been a sea change, and you will find that now there is actually a flip chart and a resource book, which is going to bring in a more visual and hands-on experience for the learners. So here, I think the training now will happen in much smaller groups with more facilitators, with more hands-on training on mannequins and on equipment. So I'm sure that this training in smaller groups, where there is more focused attention from the facilitators and there is availability of equipment and mannequins for every group, this will help in developing much better skills. So that is what I want to share in very brief about the NSSK package. And the second one is a long awaited package for the newborn stabilization units. I think it's absence has been greatly felt, because we were not able to provide the FBNC training at all levels of our health system, and also because the type of care that we provide at our sub-district facilities or FRUs is level 1 care. So this package will fill in that critical gap. And this package is very closely aligned to FBNC. So it is very good if you learn through the NBSU package and you go for the FBNC package, then it is all aligned. So there is no difference in the information that is provided. It's a very, very simple package, stepwise approach to how to deal with a baby who presents at a FRU or at a NBSU level. Also, the skills that are required to provide care at the first level of care are all included. And what we have seen in the pilot that we have done largely in the state of Madhya Pradesh is that all the doctors and nurses who went through this package felt so much more confident in managing babies at the NBCU level. And I think that is going to make a big difference to the newborn care, because if we can manage some of the babies at NBSU level, it helps a lot in decongesting the cases at the SNCU level, but also that the babies are well stabilized before referral and transport. So I think both these packages are going to make a huge difference to the facility-based newborn care. And in the coming days, you will surely hear more about the guidelines from the ministry in terms of directives and guidelines from here. So thank you, and that is from my side. Kapil, over to you.
Thank you, Dr. Dipti. In the next step, I can say that there is a proud moment yesterday also that Honorable Health Minister has also launched INAP Progress Card. Said, as we all know that in 2014, we have launched our INAP program, and sir has also told and tell us that we have achieved 2017 targets of the neonatal mortality rate and the SBR rates. So I would like to request Dr. Vivek Singh, he's a health specialist from UNICEF, to kindly share us few highlights in the progress we recently released in the INAP program by the Honorable HFM sir. Dr. Vivek, please.
Thanks, Kapil. I think the most important features in that progress card was, I will just repeat from what Dr. Agnani sir and Dr. Ghosh mentioned today, that while India has made remarkable progress since the INAP was launched in response to the Every Newborn Action Plan globally, and one of the highlights, as Dr. Agnani sir mentioned, that India not only accelerated the milestone for ourselves to achieve a single-digit NMR much ahead of the SDGs, India also included the 6th key intervention pillar of care beyond survival. And that is where not just making sure that newborns survive, but they survive with the maximum potential to transform as healthy and productive human beings. So I think these two are very important points. And one of the key features in this progress card was that while 3 accolades for ourselves, that we have scaled up the care for small and sick newborn as a country, and we have achieved these targets of ENAP released recently 5 years ahead. But at the same time, the realization as a country that we have seen inequitable progress in terms of newborn mortality reduction, and recognition of that this next decade from 21 to 30 is very important, that the gains made thus far, first, COVID does not regress those gains. And second, that now that we know where are the districts, where are the states where there are programmatic operational challenges. So now we focus our attention in the next 10 years in those areas. And the last point is, in that progress card, what is very important for us to note is the point that Dr. Agnani made, that now it is upon the states and the districts to review for themselves the progress against these INAP milestones and come up with these state and district specific plans. And that is where, if you see on the last page of that card, what the government is committed to is that in the next year, there would be regional reviews similar to what had happened when INAP was conceptualized along with all the states. So there would be regional level inquiries, and there would be state level exercise that by end of the next year, country along with all the states and districts where we need to focus will have their decadal plan. And what we all must focus, and I'm reading from the chat, is that the INAP clearly gives 3 interventions to categorize. One are essential, then second is situational, and third is advanced. And for example, that newborn resuscitation and all these versions of the new guidelines that you see will fall under essential interventions. Then situational, for that matter, let's say if HIV will have certain preventable newborn deaths or malaria related deaths in certain states, then you will have to have context specific situational interventions also for these low hanging fruits. And last is advanced. So for example, if some SNCUs are ready to take on the CPAP, then they must ensure that more lives can be saved by ensuring that we start CPAP immediately. So I think it is very lucidly laid out plan, the INAP, and the commitment of the central government that next year, along with all the states, we must embark on this next decadal exercise. So this were very important features of that launch yesterday. Thank you very much. Over to you, Kapil.
Thank you, Dr. Dipti and Dr. Vivek, for giving us some glimpse of these two things, that new released INAP progress card and the 2 training packages of NBSU and NSSK. Here, I would like to thank one of our panelists also, Dr. Sushma Nangia at the NCC, National Collaborative Center, where all these packages, NBSU and NSSK, under the guidance of Dr. Sushma Nangia, it was released. Now for the next session, I would like to request Madam to kindly guide us with the way forward and the way forward for the nation. Madam Sumita Ghosh, please.
Well, all good things come to an end. So today's excellent, deliberations, they are coming to an end now. So what next? In July, August, we had arranged 3 webinars where in general, we discussed with all the SNCUs all over the country about COVID management, about newborn care, about the critical aspects, as well as continuation of the essential care. So there we promised that we will go now by individual subject topic wise we'll go. So this was the first attempt. Yesterday, of course, we had a very successful webinar with the nursing fraternity, where we had 8,000 registrations and 7,000 plus participation, along with YouTube views. So this is going to be a popular, and it is going like a movement all over the country. So we promise that we'll also come out with such a webinar, on topics, special topics like today, in detail, and maybe in more detail and in more context specific, like what is possible in SNCUs, how it can be, our SNCUs, how they can deal with the subject. So we promise that will be a way ahead. Another thing, we yesterday in the Honorable Health Minister meeting, it was Additional Secretary and Mission Director said that SNCU quality certification in the line of Lakshya. So again, that is coming in your way. So we have all of you from the SNCUs, you have to try hard how we can, the quality improves, and the certification, of course, will come out with some mechanism how that will be done, but we should all gear up to this, that our quality becomes our, along with coverage, quality becomes the next thing now. We also heard from the states, it is always very refreshing, to hear the good things, the good practices the states are doing. So we had a session, and it was, I was very happy to hear such small kind of innovations have given such big jump in the quality. So again, I would request that every state like should go ahead with such kind of, you know, interstate webinars or consultations. One essence youth should speak to other, what are the good practices someone is following, so that the collective quality improves. So that will be another takeaway message from here, this webinar. The thing we already have heard that the new training packages has been modified and NBSU training package has newly been developed. So again, I'll request the states that it might take some time before we disseminate, because we again will do some kind of, you know, internal piloting, internal reviewing, do some exercise, and within a month or so we'll be disseminating it to the states to take it forward. Now again, another thing which I would like to say that now yesterday's clarion call was there from HFM that we must see each newborn being as an individual around whom there is a lot of hope, anticipation, lot of expectations, and this, when they fall sick or they need some kind of care, they are handed over to us by the families. They believe in they trust and believe in our, you know, competence, our attitude, our care. So I request that all the SNCUs and all the newborn facility-based newborn care, especially whom we are talking to now, should gear up, that we keep alive that hope and we prevent each and every preventable neonatal death. So that should be our mantra. Next, like we would, that is the only way to go forward, that each case is an individual case, and we must treat it with the dignity and the equity and the quality it deserves. Today we have 7,200 registration. So I believe somehow they are listening to us. This online platform has given us this opportunity to reach so many people at the same time. And all the functionaries who are present today, they should take these messages forward. I thank you all for being here, and we are all together, and we will you know, make realize, we'll, you know, make our dream be real in time to come. Thank you very much for your time.
Thanks a lot, madam, for your guiding words. Now, with the guiding words of the madam Sumita Ghosh, we are closing this webinar with thank you.
Thank you. Thank you.
Thank you, everyone. Thanks, ma'am.
Thank you, Madam Ghosh, and thank you, Kapil, for conceptualizing this and making this happen.
Thank you, everyone. Thank you.
Thank you.
Thank you.